Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with the heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Құрметті ханымдар мен мырзалар,
Good
бүгін
morning,
саммиттің екінші күні
dear
өкпе
ladies
қателесі
and
тақырыбына арналады. Әр
We are
баяндама
welcoming
басталмас бұрын
you
және аяқталған соң
at
онлайн
the
викторина
best of
өткізіледі. Онлайн
ASCO
викторинаға
Summit
экрандарға көрсетілген QR-кодты
2023. There
сканерлеу
will be
арқылы қосылуға болады. Жауап беруге 3
list
минут
of
уақыт
questions
бөлінетінін ескеріңіз.
shown to you on the link.
The second day of the summit is devoted to the topic lung cancer. Before and after each report, an online quiz will be held. It will be possible to connect to the online quiz using QR codes that will be displayed on the screens. Please note that you have 3 minutes to answer.
Құрметті Жамиля Жолдыбай және Эльвира Сатбаева, өкпе қателісігі клиникалық ғылыми симпозиумға модераторлық ету үшін подиумға өтулеріңізді өтініп сұраймыз.
Dear Jamila Joldabay and Elvira Satpaeva, we kindly ask you to occupy your seats for the moderation of the Clinical Sciences Symposium, Lung Cancer.
Құрметті қонақтар, баяндамалар барысында спикерлерге сұрақтарыңыз болса, спикер сөзін аяқтаған соң қолдарыңызды көтеріп, микрофонның әкелуін күтуіңізді өтініп
Dear
сұраймыз.
ladies and gentlemen, please take
Dear guests,
microphone.
in case you have any questions for the speakers during the report, please raise your hand and wait for the microphone to be brought. Thank you.
Good morning, dear colleagues. Welcome to the Clinical Sciences Symposium Lung Cancer and Best of ASCO 2023. Today we are chairs. I am Joldabay Jamila, Kazakh National Medical University, Almaty, Kazakhstan, and my colleague Satpaeva Elvira Bulatovna, Almaty Cancer Center. And today we have 2 speakers, Dr. Alexandra Panina and Dr. Madina Orazgalieva. And I'd like to invite our first speaker, Dr. Alexandra Panina, leading specialist of radiology and nuclear medicine department, Kazakh Institute of Oncology and Radiology, Almaty, Kazakhstan, with topic evaluation of change in recessed tumor size and survival in patients with rare cancers treated with checkpoint inhibitor therapy, SWOG S1609. Please.
Good morning, dear colleagues. Thank you for kind presentation, Jamila Joldbay. Good morning, dear colleagues. It's a big honor for me to present the results of study from our colleagues from Seattle and Friend Hutchinson Cancer Center. But before we proceed to the presentation, it's necessary to ask few pre-test questions, which you will see on the screens. Please take your phones. You need to scan the QR code and ask the first question. Let me read the first question of this section. The first question is the criteria for assessing the response in solid tumors, RECIST, as we all know, used to assess changes in the tumor node over time classify A, full response and partial response, B, all answers are correct, C, stabilization of process, and D, progression of the process. Okay, now we are moving to the second question. The second question is partial response according to RECIST means A, reducing in tumor size by 10%, B, reduction in size by 50%, C, reduction in tumor size by 30%, and the D, reduction in tumor size by 33%. Okay, and we're moving to the last one. Third question is, which RECIST category corresponds to a change in tumor size by 29%? A, partial response, B, full response or complete response, C, stabilization, D, progression. Okay, now ответы. Now we got the answers. Okay. Well, discussion of the answers will perform after my presentation. Now we can move on and start the presentation. So my topic is evaluation of change in recessed tumor size and survival in patients with rare cancers treated with checkpoint inhibitors therapy in framework of this WOC S1609. As we, here is disclosure slide, no conflicts of interest. As we all know, RECIST has been used for over 20 years to evaluate the change in tumor burden. The main point of RECIST is to define the target lesions, measure its sizes, sum up these measurements, and make a conclusion. Depending on changes of the sum, we can establish one from 4 categories. These categories are complete response, partial response, stable disease, and progressive disease. The description of these categories you can see on this slide. But as RECIST have been around for decades, there has been plenty of time to show when we use this quantitative assessment and we group this data into the categories, some of the information may lost. So one of the example we can see at this slide. This research was published in 2012. Here we can see the cohort of patients who was treated with chemotherapy in phase 1 trial. So what we can see, this analysis showed that in fact there was a linear association in tumor changes between the pre-treatment scans and first scan after the treatment in both overall survival and progression-free survival. There is no evident threshold effect for those levels defined by the RECIST criteria. So what was the main question of the authors of this research? How do these associations look with checkpoint inhibitor therapy? It was a very unique research. The name of this research is S1609 or DART clinical trial. The data from this research was open at over 1,000 sites. It was basket design with 53 baskets. The cohort of patients was 798 with patients with rare cancers of different localizations. Patients received CTLA and PD-1 combination immunotherapy. So what was the main questions that was interested in the authors? First of all, it was overall and progression-free survival. Also, author used landmark analysis, and the critical point was date 65. In terms of statistical methods, they used Kaplan-Meier estimates, Long-Mart rates, Cox regression models, martingale residuals, and Pearson correlation. So here we can see the cohort of this study. The median range and the number overall description you can see in this table. So a little under 10% of the patient who was enrolled in the study were not eligible primarily due to enrolling without actually a rare cancer, so they were excluded from the study. And remaining 70 patients also were excluded from the study because they died. So the median age of participants was 60 years. Slightly more than a half was female, And performance status for 58% was 1 and 2, and the remaining had performance status 0. Here you can see the distribution of localization of rare cancers. Overall, it was 53 baskets, but it was very hard to put all of them in this small slide. So here you can see the main localizations. It was gastrointestinal, genitourinary, gynecological, head and neck cancers, lung cancer, neuroendocrine, and other rare cancer subtypes. As we can see, it's very balanced distribution of almost all types of cancers. So the first thing authors did, it was watch the martingale residuals. Martingale residuals we need to find to further use them in the Kaplan-Meier graphs. So here we can see two plots for overall survival and progression-free survival. What we can see here is the pretty linear trend all the way up into 50% increase in tumor between those two scans, before treatment and after the treatment. And we see similar shapes for both, for overall survival and for progression-free survival. Then the next step was for authors to create Kaplan-Meier curves for progression-free survival and for overall survival. There are a lot of data, a lot of colors and lines, and it's a bit hard to define whether any specific feature of the study. But we can see the overall trend. It's like similar for progression-free survival and overall survival. To watch in more detail, next step for the authors was to take some particular features from study and to perform the Pearson's correlation. So here on this graph, we can see the Pearson correlation for patient with 1 year overall survival, just like example. So here we can see rather strong correlation with 0.9, and it was statistically significant data. So to conclusion, the authors said that there is a strong linear relationship between percent change in tumor size and outcome with no inflection point and tumor change size based on classic criteria for progressive disease and objective response. Also, I want to thank on behalf from the authors and from us, all the patients who take place in this very valuable research, all the staff and data coordinators with SWOG and sites, and of course the authors who provide us this information. Thank you. Now we will ask the same questions from the test again, and we'll see whether any improvement in your knowledge. So, the first question. Мне читать? Мне опять читать, да? Okay, please.
We see together 2 points of nose on the post-test. Можем посмотреть до, pre и post. Нет, и pre и post-test. Pre и post-test. И pre и post-test есть?
Ничего не видно пока на экране. Все хорошо. Мы ждем. We are waiting for your answers. the answers is in their weight. Oh, okay. So here we can see the answers for first question. Most of you gave the right answer.
Which?
The first question is the criteria for assessing the response in solid tumor used to assess changes in the tumor node over time classify as. Most of you choose all of the answers are correct. Means full response, partial response, stabilization and progression.
То есть там было все ответы правильные.
Да,
Ну,
все
чуть-чуть
правильно.
это комментируйте.
Мы можем перейти дальше к следующему вопросу.
So let's continue with the next question.
So, во втором варианте у нас
In the second
немножко
question,
разделились мнения.
there are different opinions. The majority answered correctly, C.
Согласно РИЦИСТу,
The reduction in tumor size by 30% according to RECIST scale should be reduction by 30%. So less than 30%, this is a partial reduction. And then we will comment this question. So we will have an interaction session. Yes. In case there is a progress after the first pretest, and looks like the answers were improved, because yesterday we were repeating that many times, and still in the post-test with questions, it was not enough.
помните уменьшение размеров опухоли на 30%
So the
соответствует
changes
частичному ответу.
in
И последний вопрос.
tumor should be
Здесь
by
тоже
30%.
большинство верно.
So
Жильбена, прокомментируйте.
the third question, the majority answered correctly. Which RECIST category responds to a change in tumor size by 29%? The majority answered correctly. The changes by 29% according to RECIST is referred to stabilization. The answer is C. 71% of respondents answered correctly, and this is a positive dynamics. And it was very informative, and this is exactly what we wanted to get after the lecture. This is a post-test. If you have any questions, we are ready to discuss. So,
Вопросы. Ну, у нас ничего страшного-то.
it's okay, we can speak both English and Russian. Could you please tell us, is there any link between RECIST scale and the PCI? 30% of regression, which PCI it is referred to? If you know, probably you as a radiologist, you know, RECIST is not linked, only size of tumor is taken into consideration, because RECIST is not linked to the pathomorphological data. Thank you very much for your interesting information. I have a practical question. When you make a description of the X-ray, should you indicate that it is done according to RECIST 1 or RECIST 1.1? Because it happens patients participate in clinical trials and it is required to have such a description of the imaging. Do you perform such description of imaging? Currently, RECIST is applied in our practice. This is the latest revision of RECIST 1.1. This is what we use while describing the images. Not always we described if it's a target one or not, but the conclusion we make according to RECIST 1.1 version. Another question. RECIST, is it used when there is a low sensitive tumor to chemotherapy. So the reduction by 30% makes sense. But in case there is a sensitive tumor, I'm not sure RECIST reduction by 30%, does it really play a role? Because really, it plays the role in case there is a reduction by 50% by World Health Organization guideline. If it's applicable or not, it is applicable because we took into consideration all the details. And in case of the complete response, or we can indicate it's a partial reduction or full reduction. So we describe everything, positive, negative, and there are cases when we observe the complete response, full response for chemotherapy. If not, then there is a stabilization or progressing of the process. I also would like to comment for solid tumors, we use classification of RECIST and RECIST 1.1, the latest version, measuring the sizes of the primary tumor and target tumors as well. But it is necessary to take into consideration this classification depending on the type of therapy. In case we mean one type of therapy, the sizes of the tumor plays the role, and there is dependence on the accumulation on the contrast. And in this research, it is shown that out of RECIST, there was one criteria used, only the size of tumor. In case of inhibitor therapy, not only the size of the tumor plays the role, but also there was another parameter with the survival rate, but also there was multi-factor analysis with the radio research, visual diagnostics in case of lung cancer. So using radiological methods, for that we use RECIST criteria, and in territory of Republic of Kazakhstan, radiologists do not use RECIST scale, but this is a multifaceted analysis. They indicate it as a stabilization or progressing, depending on the percentage in tumor changes. But in fact, it should be a multi-factor analysis, even during the radiological method of study. It's just my point of view. In case of target therapy, you cannot reach it that way. The stabilization is already considered as a good effect, and then it is efficient to use this scale. But when you speak about chemotherapy, this is just my personal opinion, being a clinical expert, there should be another criteria, for instance, using WHO guideline. In case of target therapy, even 30% of reduction is already a good result, as far as I know. So better you indicate it as a target therapy. A RECIST scale is for solid tumors, mainly. So that was the topic of the report. Dear Nina Apollonovna, Kaldegul Kabakovna, I have a question. Good morning, dear colleagues. I have a reasonable question to continue this discussion. How far in your practice, you being practical clinicists, how often you see the response for immune therapy? Because in this case, this research was made using quite serious inhibitors of the checkpoints, and there should be an appropriate cohort of patients. We should also take that into consideration. These are rare tumors with a very strict selection criteria. Thank you very much for your comment and question. Yes, in our practice, we see patients who were treated by immune therapy, but not so many of them. This is just a new direction. And like Nina Apollonovna mentioned, very frequent we see stabilization of the process, because mainly these are the patients who got other lines of chemotherapy. Usually they are grades 3 and 4. In case of those processes, it's very difficult to get a complete, full response. Usually it's stabilization. Of course, it depends on the stages, on efficiency assessment, depends on the course, on the monitoring way. There should be particular criteria to assess treatment. For instance, if you assess it just after one treatment course, it's not correct. Okay, let's continue.
I would like to invite here Madina Orazgalieva, candidate of biological science, head of the Center for Molecular Genetic Research, Kazakhstan Institute Oncology and Radiology, Kazakhstan, and her presentation, methylated DNA biomarkers and incident cancer in the American Cancer Society, Cancer Prevention Study 3, CPS 3 cohort. Please.
Good morning, dear colleagues. We have some questions about liquid biopsy. Sorry. We have some questions, and first question is, in what cases is liquid biopsy used in oncology? A, in the primary diagnosis of tumor disease of any localizations. B, with diagnosed cancer in the absence of tumor material in order to study the molecular profile of the tumor and the selection of optimal therapy. In young patients with rare forms of malignant tumors, ED, with common stages of lung cancer, breast cancer, CRC, sarcomas. Second question, what kind of factors affect to the frequency of detection of tumor markers? A, aggressive cancers have higher detection rates. B, conditions and storage of samples. C, lower overall detection rate of observed in a population with less aggressive cancers. D, all answers are correct. And the third question, the frequency of biomarker detection in the case of aggressive cancer suggests A, the possibility of early intervention and risk prediction. B, correct staging of the disease. C, possibility of using personalized therapy. D, can determine reliable prediction in individuals with a body and family history, for example, breast cancer. Oh. And after my report, we have discussed about this. And
Следующий, да, давайте вопросы, но в конце уже будет.
Не, вы просто сейчас сначала акцентируете, что на первый вопрос вы ответили так-то, и после лекции мы будем
First of all, I believe we have to look at the respondents' answers. And as for the first question, most of the respondents, more than 80%. Yes. Second question, 81% believe it's D. And third question, there are split answers. A and C mostly equal. Then we have some B and D. We will have a look at the correct answers after the presentation.
And my report today is dedicated to mutilated DNA biomarkers and incident cancer in the American Cancer Society, ACS, Cancer Prevention Study 3, CPS 3 cohort. This collaboration between ACS and GRAIL company has uncovered unique insights into cancer biology, which I am excited to share with you today. Let's rely on cancer signal detection in blood, which is determined by cancer biology. Circulating tumor DNA, ctDNA, is shed after cancer onset and over time continues to be released during the shedding window. Cancer signal detectability starts at the limit of detection and continues through treatment and monitoring. The earlier detection opportunity is defined by a preclinical detectable window. The preclinical detectable window is from the time of cancer signal detection to clinical diagnosis. In this study, blood draw occurred prior to clinical diagnosis in the preclinical detectable window. Multi-cancer early detection tests can be used to evaluate blood samples drawn during the preclinical detectable window. In this study, authors used the GRAIL cell-free DNA-based MCED test. Cell-free DNA-based multi-cancer early detection tests detect clinically significant cancers. MCED test can also assess pre-diagnostic changes through retrospective studies with adequate biobanked blood samples. Retrospective analysis of cohorts such as Ontario Health Study and the Taizhou longitudinal study have evaluated DNA methylation in plasma from 1 to 7 years prior to clinical diagnosis. This analysis suggested that tumor-associated cell-free DNA signals may appear in the blood years before the standard of care can detect cancer. ACS CPS 3 is a large prospective cohort study of 300,000 volunteers. It was one of the only cohort studies which had a sufficiently high volume plasma sample available for this type of analysis. This cohort offered an opportunity to observe detectability of MCED signal in the preclinical detectable window between blood draw and conventional diagnosis, up to 3 years. However, there were limitations, which include plasma samples differed in the CPS3 cohort from prospective MCED samples in that. Frozen samples from 9 to 15 years versus fresh samples. EDTA tubes versus Shrek tubes. And second spin, no second spin for ACS samples versus irregular samples. The ACS CP3 cohort include individuals aged 30-65, which is a relatively low risk population and differs from the population that the MCED tests has validated in. And the design of the study. There were more than 300,000 CPS3 participants after initial exclusions, including revocations, missing linkage with the state registry for cancer, no specimens, unknown age, etc. There were approximately 268,000 remaining CPS3 participants. Of 268,000 CPS3 participants, 245,000 were included in the qualified participant set. Of those, 2,850 cancer and non-cancer participants were sampled for the selected participant set, and 2,754 participants were included in the primary analysis set. A total of 82, it's about 3% samples from the 2,850 clinical evaluable set did not pass quality control and were excluded as not evaluable. For participants diagnosed with a liable cancer, certain cancer type that had relatively high incidence in the cohort were downsampled to absolute numbers of included participants comparable to other less common cancer types. As for participants who were not diagnosed with a liable cancer, stratified sampling was considered to achieve a non-cancer to cancer ratio 1:1 in the strata by age and sex. Cancers that were subject to downsampling to achieve target ratios 15% for all except breast cancer included breast cancer with stage localized and melanoma, thyroid cancer and uterus cancer with stage localized and prostate cancer with stage localized and Gleason score less than 7. As a definition, an liable cancer diagnosis included all invasive cancer except non-melanoma skin cancer, in situ urinary blood, any other cancers that were fatal within the follow-up period, including beyond the 3 years considered for other clinical outcomes. In the next slide, we have a table with participant characteristics. ACS CPS3 cohort is a healthy young population. Participants' baseline characteristics were similar by design. Overall, the cohort was predominantly white, it's about 85%, and female, about 75%, with about 50% having a college degree. Most participants were never smokers, about 70%, and about 5% were current smokers. Overall cancer incidence rate is about between 0.32 and 0.35, which is lower than the SEER incident rate, about 0.46%. SEER is like population cancer register. Mortality was 0.1% per year. CPS3 does have lower deadly cancer incidence rate versus SEER 28 versus 71 for 100,000 population. In this slide, we have some results of this study. Please note that the test performance is with weighting applied to represent the original study population. This healthy young volunteer cohort has high incidence of early stage, relatively indolent cancers such as thyroid, which reduce the overall detection rate. Fatal cancers by definition are not indolent, and high detection is observed in that group. The cancer signal detection rate increased as the time between blood draw and cancer diagnosis decreased. Lower overall detection rate than expected from SER was observed as expected in a population with reduced rates or deadly cancers relative to other cancers. And false positive rate was 0%. None of the non-cancers gave detectable signal despite being matched to cancer for age and sex. Aggressive cancers gave high detection rate, including eventually fatal cases of any cancer type. Overall, signal detection among cancers was 15%, 6%, and about 2% for samples collected 1, 2, and 3 years prior to diagnosis, respectively. Overall, TPR for cancer signal detection increased as time between blood draw and diagnosis year decreased. TPR by cancer characteristic over the 3 years showed that signal was detected for clinically significant cancers prior to diagnosis. TPR for fatal cancers was 55%, 21%, and 5%, 1 to 3 years prior to diagnosis, respectively. Compared with 10%, 4%, and about 2% for non-fatal cases. And accuracy of prediction of cancer signal origin. The main overall accuracy of SCO prediction was 81%, 88%, and 95% for samples collected 3, 2, and 1 years prior to diagnosis, respectively. The top 5 SCO predictions were head and neck, breast, colon rectum, lymphoid neoplasm, and plasma cell neoplasm. Of note, the average lead time among those cancers detected with 323 days. However, 40% of cancers with signal detected were detected beyond 1 year before clinical diagnosis. For example, a regional stage colorectal cancer was detected 991 days prior to diagnosis. A localized tight liver bile duct at 946 days prior to diagnosis, and a distant stage ovarian cancer at 916 days prior to diagnosis. Highlighting that cancers were still being detected up to the end of the study period. It's important to note that the case mix differs among stages, so detection rates are not directly compatible, and that the stage of cancer's status at the time of blood draw is not known. And the high efficiency of detecting eventually fatal cancers in this non-interventional study has implications for risk of death. This suggests our diagnostics of indolent cancers is not likely. Individuals with negative test results are diagnosed with cancer already well controlled. Less than 50% risk for those in the first year. Cancers have an average about 1 year detectable window, including cancers. Clinical diagnosis happens to fall within the first year of this non-interventional study. This window size may allow earlier intervention to occur. In conclusions of the study, after sets, the cohort was comprised of healthy, largely female and never smoker volunteers aged 30-65 and lower than average risks of overall cancers and particularly deadly cancers. Because the cohort banked sufficient plasma, it offered a unique opportunity to probe the preclinical detectable time window. However, time in storage in the freezer may impair cancer signal detection. The results should be reassessed in the intended use population aged 50-79 with average and not lower risks of overall and deadly cancers. Cancer signals were detected in preclinical blood draws with high efficiency for eventually fatal cancers, which underscores the need for earlier intervention in those cases. Additionally, cancer signals were detected up to 3 years prior to conventional diagnosis with an average lead time of 1 year and suggests the potential for annual screening intervals. The samples may have had limited signal due to time in freezer storage. Additional studies are needed to confirm the results using fresh samples with current storage and processing practice and in pre-diagnostic samples, specifically serial samples from interventional studies. Thank you for your attention. This study.
Большое спасибо, Мадина Гинаятовна. Наверное, сейчас мы приступим к повторному тестированию с быстрым обсуждением.
And now let's make the second time the quiz once again. Shall I read the questions? So what are the results of the second time testing?
Да, мы ждем статистику. Итак, я быстро прокомментирую в отношении динамики.
So I will comment quickly the dynamics of the testing. Initially, the answer B for the first question was chosen by 73% of participants. Currently, we see the obvious dynamics, almost 90%. And B is the correct answer. The question was, in which cases the liquid biopsy is used in oncology? And the correct answer is B, with the diagnosed cancer in the absence of tumor material in order to study the molecular profile of the tumor and the selection of optimal therapy. In the primary diagnostics, the answer A, it's not correct. The answer C is not correct. D is either not correct. The next question, which factors affect the frequency of detection of tumor markers? There were all the answers listed here. The terms and conditions for the sample storage, this is what was explained in this presentation. And the lower level of detection is in the aggressive types of tumors. This is the main message in those 2 days of our summit. So, means the answer is D. All answers are correct. Initially, 81% of respondents answered, now it is 89% of answers. And the third question is about the frequency of biomarker detection in case of aggressive cancer. So what it suggests, there were 4 possible answers. First, A, the possibility of early intervention and risk prediction. The answer B, correct staging of the disease. The answer C, the possibility to use personalized therapy. The answer D is it can determine reliable predictors in individuals with a burden in family history, for example, breast cancer. So the correct answer is A. If there is any comment, I understand that some people chosen the answer C. Probably we should formulate the question precisely, because no one is removing the customized, personalized therapy from the liquid biopsy method. But the main topic is the early prognostics in the origin of the disease. So that's why, in this regards, the most correct answer is A. Thank you very much. If you have any questions, you are more than welcome. Nina Apollonovna, please take the microphone. Could you please tell us your genetic method? Can we make genetic screening for population in order to detect early forms or non-obvious forms of cancer? Same like we do other types of screening for different cohorts of population. Can we apply your method as a screening? Thank you very much for your question, dear Nina Apollonovna. Yes, with that particular target, we performed the large-scale study. 300,000 participants participated from healthy population over there. The main no, not to make methylated DNA. It's not about changes in DNA, it's the pre-change in DNA. Because in DNA there were no changes. So we check the parts of DNA that are regulating mutation, such as sections responsible for reading and other functions. The main dissatisfaction of medical workers and scientists with such research, why this study cannot be used as a screening, because there was a high share of hyper-diagnostics possible, because in the body there are regular changes in nervousness, and the immune system is getting that information and it's circulating in the blood. This is what we catch, and we can be mistaken in the false positive results. Before this trial, there were no trial to make screening. There are some commercial firms, companies, they are doing some studies, but this is not exactly suitable for screening. Why I was surprised with this study, because there is a percentage of false positive results. Not even just 0.001, but just 0%. And with such a large-scale cohort, we should check all the articles referenced in this study. But in this site, in this study, it's not indicated what kind of sections were sampled for mutilation. Now, Grail company is a commercial company that is producing those tests for mutilation. So in that regards, this is very interesting to know. And in the summary point, it is mentioned that we should standardize the sampling, we should standardize the selection of the population, and only then screening would become possible. The blood should be sampled once in a year, and then we can check the aggressive tumor's origin. Sooner better we catch it, because aggressive tumors, they're very fast. And then probably it will make sense to make a screening. No promises made, but 0% of false positive results. It's impressive. Let me add, first of all, let me thank you. You have already answered to my possible next question regarding mutilation sites. And let me comment, most probably you are speaking about sensitivity, and we should pay attention that this is a retrospective study, large-scale study, big one, very interesting message with a huge cohort of patients with such obvious summary. And still there is an ambition to make this study as a screening later on, because here we are speaking about the detection of aggressive forms of tumors, and there were 40% mentioned. That is good enough during 1 year. It's impressive number. In case there are other questions, you are more than welcome. Thank you very much, Madina Giniatovna. Yes, the cohort is very big. Have they performed the analysis of population with the family history in the past? Probably it can be a target audience. Did they make it during this study? Did they check with those patients if they had cancer in the family history? Thank you very much, Aygulka Bakovna. So their main target was the screening. That's why this cohort is having better health. But it was characteristics: smokers, non-smokers, ethnicity, origin, age, sex, education, student, non-student, higher education, no higher education. Or probably they wanted to understand the social status, to understand that indirectly. Madina Giniatovna, the next, it is not a question, but this is regarding the prospects for the liquid biopsy method and its relevance in oncology, even during testing. I wanted to listen from you, being genetical expert, the head of genetical molecular sciences. What is the prospect in this country, in Kazakhstan? basing on what we have now. The prospects are quite good. I cannot say that the methodology is more expensive than regular PCR. There are some details. Yes, you should introduce the process. There are some particularities, but it's not difficult at all. There are laboratories established. There is a new laboratory established in Uralsk city for genetic molecular studies. I believe that liquid biopsy will be developed here, and it's much easier than the tissue biopsy. The sensitivity of the method is getting more developed, and the technologies are improving the sensitivity, and I believe the prospects are very good. Thank you very much, Madina Giniatovna. And still, can I comment being a pathologist? Because almost each year we arrange the training schools for our doctors and technicians who are participating in histological processes and other processes. A couple of words regarding standardization, because any method, in order to have higher sensitivity and higher specificity, it needs to be standardized. And it's not only about laboratories available in oncological centers. There are quite a lot laboratories will be established in the private clinics, and I'm sure it will be relevant for us, you and me, the issue of future standardization. You being a genetical expert, could you please comment that? Thank you very much, Elvira Bulatovna. This is one of our main pain. I really don't know what is the situation in pathomorphology. It is the same, but there are new methods and standardization is not catching up. We're trying to elaborate some norms and standards, but this is just our wish. But it should be originating from some governmental body or from some association. I would like to comment. Dilara Radikovna will say, yes, initiative should be from you, from pathomorphologists and from genetic experts. We are not governmental bodies. We are Kazakh National Institute on Oncology and Radiology. We are the flagman of the studies and standardizations. So please initiate the standardization process. Yes, laboratories can be launched anywhere, even each street, but the most important is to make them work in a quality way, in a correct way, and because of that, the diagnosis can be wrong, and the process is getting longer for the patient. So that's why, please, you should not disperse your efforts to all the laboratories. Just to install equipment and to buy reagents, it's not all. It does not guarantee that laboratory will provide a quality work. So a big number of the new methods should be introduced gradually. There are so many rare tumors, heterogenic tumors. Sometimes we are not able to diagnose them. So I believe that for that cohort of tumors, we may use this new methodology. You being pathomorphologists and genetic experts, you should assist us. You should initiate this process, and then we will coordinate that with governmental bodies. Thank you very much, dear Dilara Radikovna. In case no questions, probably you have some comments. Yes, we are on time. Thank you very much for coming to this session, for the active participation, and for your interactive discussion. I believe that those two abstracts and presentations enabled us to get new knowledge in the sphere of clinical oncology. Thank you very much for
Спасибо
that.
большое, я тоже присоединяюсь
Thank
к
you.
всем словам.
I'm joining
Потому что действительно
all
очень
the words
интересная,
that you
сегодня
just
получилась наша
said
секция.
right now. Our section
Такая
was
очень
very interesting,
базирующаяся на научных
based
знаниях.
on the
И всё-таки возникает
scientific
надежда на то,
evidence,
что
and
не всё
we
ещё
hope
потеряно онкологии,
that
что мы в будущем сможем
oncology
действительно
works
использовать
well, and in the
достаточно
future
большие
we
базы
would
и
be able to
серьезные
use
методы для
big
их
data,
анализа. Спасибо
big
большое.
databases
Коллеги,
for analysis.
благодарю вас за
Thank you very much, dear
проведенную
colleagues,
успешную секцию,
for this
за ваши
successful
вопросы.
session, for your questions.
Всех поздравляю со вторым успешным днем
Let me
нашего
congratulate you with the
саммита
second
«Посто
day
АСКО». И я бы
of
хотела
our
обратиться ко
summit,
всем нашим
Best of
участникам,
ASCO
слушателям,
2023.
экспертам,
And
модераторам.
let me ask
При использовании
moderators,
презентации, материала,
speakers,
который был
participants,
предоставлен
while
сегодня в
using
течение
the
этих дней,
presentations and
пожалуйста,
materials
соблюдайте
provided in
критические
those
вопросы,
2 days, could you please comply
упоминайте,
with
что все
ethical
материалы
issues?
используются только
All the
лицензионные, и что
materials
это
to be
авторское
used
право
only
за АСКО
if
и
you are licensed to
Казахстанской
use that.
ассоциации онкологов.
All the materials
Тиражирование
are
материала не
provided
подлежат
by
только с
the
использованием, с
Kazakhstani
разрешения АСКО и Best of
Association
ASCO.
and
Спасибо.
ASCO and Best of ASCO. All materials are provided basing on
Құрметті
their
модераторлар
permit.
және спикерлер, сіздерге
Dear
үлкен рахмет.
moderators, dear speakers, thank
Құрметті
you very
қонақтар,
much
дәл
for
қазір
that.
сіздерді осы ғимараттың бірінші қабаты көрме аймағында өтетін кофе брейкке шақырамыз.
Dear guests, now we kindly invite you to a coffee break, which will be held on the first floor of this building in the exhibition area. Thank you.
Coffee break time.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более 100 миллионов долларов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологий и производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. Быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with Doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with Document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Dear Victor Kim and Kaldıgul Smagulova, we kindly ask you to occupy your seats on the podium for the moderation of the Clinical Sciences Symposium Lung Cancer.
Good morning, everybody. I welcome to all participants to the Best of ASCO 2023 of Kazakhstan. We're starting the lung cancer session. We plan three most interesting reports: modern methods of radiotherapy, targeted therapy, and checkpoint inhibitor therapy for early stage lung cancer. I give the floor my colleague, Viktor Borisovich, to introduce for first speaker.
Good day, dear participants. We are very much glad to welcome you in our summit at the Best of ASCO. The floor is given to Professor Mr. Cem Parlak, Associate Professor, Oncologist, Radiologist from Turkey. Professor Parlak, the floor is yours.
Please. Before starting, I would like to thank to the all our colleagues involved in that project. I mean, it's because it's very important in our clinics, in our practice. ASCO is the, as everybody here know, mostly defines all the results presented in ASCO defines our current practices, actually. Today, my name is Cem Parlak, by the way. I'm originally Turkish, but working here in Tomotherapy Center in the Kaznior, in the Alma Medical Company. I also work in the Asfendiyarov University. So, can I see my slides? I cannot. Question. Sorry, excuse me. Will they see on the screens? They see? Yeah, okay. The first question that I will ask you questions that probably you know the format, and we will check if I'm good to explain something and change your mind or change something actually. The first question is that the most optimal approach in the treatment of limited stage lung cancer should be either chemotherapy alone or sequential chemoradiation therapy, surgical therapy with adjuvant chemotherapy, or concurrent chemoradiation therapy. We continue, okay. The second question is which study, which diagnostic tool is most relevant for the planning and contouring of radiation therapy in small cell lung cancer? MRI with contrast, CT with contrast, PET-CT, or bronchoscopy? And the third question is, which one of the following are the most effective mode of fractionation for radiation therapy in this small cell lung cancer? 66 gray in 33 fractions, 45 gray in 30 fractions, given in 2 times in a day, 50 gray in 25 fractions, 60 gray in 40 fractions, again 2 times in a day. Okay, I cannot see my slides. Okay. I cannot. Yeah, okay. Now I can see. So today I'm going to talk about the final results of an interesting study for the treatment of limited stage small cell lung cancer patients. The original study, it was done by the group from the Norway. Actually, it was published already, but the initial results were published, but they now updated the clinical outcomes and presented in the last ASCO. Just for a brief background, as we all know, concurrent chemoradiation therapy with most preferably cisplatin and etoposide is the current standard treatment for limited stage small cell lung cancer. And the radiation schedule should be twice daily, 45 gray given in 15 days, 30 fractions. But we know the results of this, the most optimal treatment that we give is still poor, and the 5-year survival rates range from 25% to 36% in previous trials, but indicating a better search for a better treatment approach. And there is a challenge in our treatment.
Коллеги, я прошу прощения. Мы ответили на 3 вопроса, но мы не увидели
We just answered these 3 questions, but we didn't see the percentage of the right answers. And at the end of the lecture, we will have a look and we'll see how the difference in answers before and after the questions. Here we have 44% most of respondents on D in the first question. The second question, the most reliable method of research in SCLC for planning and contouring radiation therapy. You see the 52% on the second option, and the most effective mode of fractionation of radiation therapy in SCLC. Here we have most D, which is 37%, and people looks like a very dim idea on how to treat the small cell lung carcinoma. So we need to find out new approaches. So D is what? It's fourth. That is concurrent countering radiation therapy, countering radiation therapy, and we don't have the common approach yet, and people pretty much diverse in their answers.
You need to do discussion about these answers. Yes.
And the most important challenge is in the radiation oncology that most of the recurrences are occurs within the radiation therapy treatment fields. So, and also there are studies to increase the dose, to increase the effectiveness of the treatment, but current studies with single fraction radiation therapy up to the 70 gray is not still good enough. So as I told you, the study was published, the initial results of this study was published in the literature, and the main aim of this study was to give radiation therapy in a common way of fractionation, like BID, I mean twice daily radiation therapy fractions, but increase the dose to 60 gray. And compare it with the current standard treatment of 45 gray in 30 fractions. So initial results show that, yes, the radiation therapy given in a higher dose of 60 gray delivered twice daily show the advantage of survival, in 2-year survival, and statistically significant survival difference. But although there is a progression-free survival advantage, it was not statistically significant. And the patients here received cisplatin and either cisplatin or carboplatin with etoposide. And in the second, after the first cycle of chemotherapy, starting from the second cycle of chemotherapy, they started thoracic radiation therapy. In one group, 45 gray in 30 fractions BID, and in the other group, experimental group, 60 gray in 40 fractions BID again. And all patients after chemoradiation received prophylactic cranial radiation. And the most important thing is that currently, actually, we do this for even non-small cell lung cancer. We don't have now elective field irradiations like mediastinal irradiations. All the treatment fields are defined with the guidance of PET-CT. I mean, only the areas with positive signs in the PET-CT are included in the treatment field. And eligibility criteria was cytologically or histologically confirmed limited stage small cell lung cancer, and the patient performance status should be well, and there should be a measurable disease and adequate bone marrow, liver, and kidney functions for effective chemotherapy. And if there was a pleural effusion, it should be clarified that negative for the cytology, and there should not be any previous radiation therapy, and also staging should be done with PET-CT and MRI of the brain. And the endpoint was, primary endpoint was 2-year overall survival, which was actually accomplished, as I told you in the initial results. And the secondary endpoints were overall survival, progression-free survival, response rates, toxicity, and quality of life measures. Yes, when we move on the results, it's obvious that there was actually no difference between two groups according to, in terms of age, gender, performance scores, and staging or pleural fluid presence and smoking history. Most of the cases were locally advanced, and performance statuses of the patients were well enough to receive all these treatments. And all patients actually, most of the patients actually could receive whole treatment, and mean number of chemotherapy courses were more than 3 in all groups. But there was dose reduction, chemotherapy dose reduction in some cases, mostly in the control group patients, and nearly all cases in the, more cases in the experimental group received whole radiation therapy, and nearly most of the patients also received prophylactic cranial irradiation. And overall, the treatment was, well tolerated, but the toxicity grade 3 and 4 toxicity is related, mostly related with the chemotherapy given, and nearly 80% of the patients received grade 3 to 4 hematological toxicities, and the toxicity related most predominantly with the radiation therapy were actually in line with the literature, which means that the treatment, higher doses of treatment with radiation treatment was well tolerated. There is no increase in the toxicity with the increase in the dose. And when we checked the response rates were, but by the way, there was no difference between groups in terms of toxicity. Which means that, let me repeat, the treatment, increasing the dose to a higher level did not change any toxicity results. And when we look at the responses, the complete response, the overall response rates were high enough, and there was no also difference between two groups in terms of complete or partial responses. And when we look at the prolonged, long-term survival results, the effect of the advantage of progression-free survival continues to be present, but there was still no difference between two groups, and the nearly as a hazard ratio, as you can see, hazard ratio is 0.77, which means that 33 patients are free of progression with the current treatment. And when we check the overall survival, the significant difference between two treatment regimens still continues, and nearly median survival in the treatment group was nearly doubled the standard radiation therapy regimen, and about 31% of cases has reduced risk of dying because of this disease. And in the conclusion, the authors concluded that twice-daily thoracic radiation therapy of 60 Gray in 40 fraction resulted in a significantly lower survival, longer survival than 45 Gray in 30 fraction among the patients with limited stage small cell lung cancer, and the higher dose did not cause any more toxicity. And thank you for your patience to listen this, and probably now we are good.
Спасибо большое. Мы еще раз должны проголосовать за те 3 вопроса, которые мы до лекции
Once again, we have to vote on these 3 questions which we had before
Я еще
the
раз
lecture,
напомню,
and now
первый вопрос
we can
наиболее оптимальным
compare.
подходом
And again, I would like to remind you the most optimal approach in the treatment of limited small cell lung cancer is first chemotherapy courses, second radiation therapy with sequential chemotherapy, third surgical treatment with successive courses of chemotherapy, and fourth competitive chemoradiotherapy. And again, We're waiting for your responses this time. Next question.
Следующий вопрос. Наиболее достоверным методом исследования
The most reliable methods of research in SCLC for planning and contouring radiation therapy is MRI with contrast, that is the first answer. Second, CT with contrast. Third, PET CT, and bronchoscopy is the fourth option. And the final third question, the most effective mode of fractionation of radiation therapy in SCLC is 66 gray 33 fraction, 45 gray 30 fraction 2 times a day, 50 gray 25 fractions, and 60 gray 40 fractions 2 times a day. We're waiting for your answers. So we've got answers for the first question. It looks like this time, if we make a comparison with your question you gave before the presentation, so here we see that the percentage after the lecture, the percentage of correct answer has been decreased significantly, 76%, which signifies the audience understand your presentation, and the correct answer is D, which is competitive chemoradiotherapy. That means simultaneous or competitive chemoradiotherapy is the optimal approach for small cell lung carcinoma. That is simultaneous or competitive chemoradiotherapy. Next question, which Again, here we have a very big difference in answers. But this is mainly because it's CT with contrast, which is B, and PET CT. Naturally, the most reliable method is PET CT, but unfortunately, not every ray therapists could afford this therapy, could afford this diagnostics. That is why most preferred CT with contrast. But those who have opportunity for PAT CT, that is the golden standard, in fact, for SCLC, and the right answer is free LC PAT CT.
They probably answered this question with their current practice. Probably they couldn't get the idea in the question, because we were not asking what are you doing or what should we do with the available modalities we have. Actually, the PET CT is now in lung cancer. Actually, let me repeat in the beginning of my lecture, is the gold standard for every kind of lung cancer, not only small cell, also in non-small cell lung cancer. If you're going to do a definitive treatment, which is not a post-operative or inoperable cases, I mean, you should delineate with the PET CT fusions.
Вопрос там был какой-то? Кто-то хотел задать вопрос?
Somebody wants to ask the question. Moderator, please. Okay, thank you. And I have a question right away. Thank you very much that you mentioned about the conditions available in the centers, but it should be a Becky for PAT-CT. That means that DECI, sorry. So DECI should be there for PAT-CT. But I would say that flat DECI for PET-CT is not so relevant because first we made PET-CT and then we make the fusion of various platforms and as a result we may find out the contours with greater precision. Of course there are PET-CT with flat decker and laser. These are very expensive pieces of equipment and it is not obligatory. Any more questions? And finally, 85% said that the most effective mode of fractionation is 60 gray 40 fraction 2 times a day. That means that the audience heard attentively the presentation, which proved that with this fractioning versus 45 gray it is non-progression survival and overall survival is higher, while the toxicity with the higher grade dosage is not different versus 45 gray. So I think the audience understood very well the main message of your presentation, and this new data will be available for radiation oncologists in Kazakhstan. And for the first question, dynamic was 30%, and on the third question, practically 50% of respondents changed their mind before and after your presentation, and that means we want to thank you again for your kind presentation. Any more questions? Any more questions to the speaker?
It is with great pleasure that I would like to give the floor to our colleagues from Georgia, Ivana Kiladze, MD, Associate Professor, Head of Clinical Oncology Department, Clinical Oncologist, Caucasus Medical Center, Georgia. Overall survival analysis from the ADAURA, trail of adjuvant osimertinib and patients that resected EGFR mutation, stage 1B, 3A, non-small lung cancer. Please, Ivana.
Микрофон не работает. По-моему, не слышно.
So thanks Kazakhstan for everything, for friendship, for great hospitality. Greatly appreciate. It's my second time in Kazakhstan, and I think that it's a fantastic country. All of Georgians love Kazakhstan, and now I understand why this is. So today I will present results of ADAURA. This is results which is excellent, I will say, because sometimes we treat patients and we have a lot of trials, but all these trials not focus on overall survival. So we have excellent results from ADAURA, which shows the primary endpoint with excellent results, and now we have overall survival or endpoints, which is 5-year overall survival. Before my presentation, I want to, I will start with questions. Okay? Let's start.
First question.
So first question. I can't see in monitor. Okay. The first question is overall survival analysis. EGFR mutation is...
Что-то вопросы не работают, что ли, или что? Нету на экране. Это не та какая-то ссылка, что ли?
So looks like the questions are not shown on the screen somehow.
Ни у кого не работает.
The link does not work.
Вот сейчас пошли, да.
Okay. The first question is EGFR mutation is recommended. A. Patients with non-small cell lung cancer 1B, 3A after radical surgery. B. Patients with advanced unresectable stage of non-small cell lung cancer. C. With any form and stage of lung cancer regardless of the histological type of tumor. And D, the answers A and B are correct. То есть определение EGFR мутации показано.
So we see the determination of EGFR mutation.
The next question. The recommended duration of usage of osimertinib in adjuvant mode after radical surgery is 12 months, 36 months, 6 months or 24 months. То есть рекомендуемые сроки применения osimertiniba в адъювантном режиме после
A, 12 months, B,
составляют.
36 months, C, 6 months, D, 24 months.
Okay. The patient is 26 years old, underwent radical surgery in volume, lower lobectomy on the left, mediastinal lymph node dissection. The postoperative stage is stage 2A, R2, G2. EGFR positive, what are your further recommendations? A, it is osimertinib in adjuvant mode for 3 years after radical surgery, standard chemotherapy, a platinum compound 4 courses followed by dynamic observation. C, standard chemotherapy, platinum compounds followed by immunotherapy with atezolizumab for a year. And 4 is dynamic observation. То есть пациенту 26 лет, проведена радикальная операция, лобектомия,
So the patient, 26 years old, underwent radical surgery in volume, lower lobectomy on the left, mediastinal LD. The postoperative stage is 2A. So there are answers on the screen for the first question. So the majority chosen the answer D. The next, second question answers different answers. 26% for the answer A. The question 3. The majority answered A, 77%. So the answer is osimertinib in adjuvant mode for 3 years after radical surgery. So let us continue.
Yeah, okay. So, excellent study because we have the primary endpoint and now we have overall survival results. By the way, I'm Dr. Giladze, medical oncologist working in Caucasus Medical Center in Tbilisi. As secondary, my job is Ilia State University in Tbilisi. We all know that lung cancer is very, very brutal disease. More than 2 million cases of lung cancer worldwide annually, and non-small cell lung cancer represent approximately 80% of all diagnosed. Approximately 30% of patients have resectable disease. And EGFR mutation prevalence is very, very different across geographical areas, from 10% to 50% in patients with non-small cell lung cancer. So what was the ADAURA? ADAURA was a study which shows how anti-EGFR tyrosine kinase inhibitors will impact on disease-free survival in adjuvant setting. So patient after surgery and plus minus chemotherapy, adjuvant chemotherapy received adjuvant osimertinib one group and the second group received placebo. So osimertinib is the first EGFR tyrosine kinase inhibitor to show significant overall survival benefit in a phase 3 adjuvant study. So it's a great results which we have now, the only anti-EGFR drug. Survival outcomes is, we all know that's not very good. Lung cancer is a leading cause of death, almost 1.8 million deaths annually. In Georgia, I think that in Kazakhstan the same, that it's a leading cause of death in oncological cancer patients. So global 5-year overall survival for stage 1B is 65-75, 50-70 in stage 2, and in stage 3A it's 30-45. we know that it's very, very low rate of survival. So how to improve this? First of all, EGFR mutation are common oncogenic drivers in non-small cell lung cancer. If we look at this map, we can see that it depends on geographical areas. For example, in Asian populations, 30–50% are EGFR positive, and in European countries and in North America, it's 10–25%. In Australia, it's 25–30%. This is a very nice example of ADAURA, the trial, the patients who were with stage 1B, 2 and 3A non-small cell lung cancer underwent surgery, plus minus chemotherapy, and then they were divided into two groups. First group received osimertinib once daily, 80 milligram for 3 years, and the second group received placebo once daily. So stratification was randomization 1:1, and planned treatment duration was 3 years. Keeping in mind that primary endpoint was disease-free survival by investigator assessment in stage 2 and stage 3A. The key secondary endpoints were disease-free survival in overall population, DFS rates, landmarks, and overall survival as safety. So it's very important because in adjuvant studies, the primary endpoint is always disease-free survival. Because if any study meets the first criteria, which is disease-free survival, then the secondary endpoint is overall survival. We have a lot of such studies which met primary criteria, but it wasn't translated into overall survival. So what was in this case? Adjuvant osimertinib has significantly improved disease-free survival. When I first read this study, which was published in 2020, it was just unbelievable because hazard ratio was 0.17, and then updating the study showed the hazard ratio 0.20. It's a huge difference to patients with or without osimertinib. So it shows the best results. The second very important central nervous system metastasis in non-small cell lung cancer, and adjuvant osimertinib has significantly improved CNS disease-free survival. You see here nice curves with disease-free survival in CNS. So about these studies which I mentioned, these studies are from 2015. The first was erlotinib, this RADIANT study, erlotinib versus placebo. The second was gefitinib after 5 years, osimertinib then with placebo, and the IMPACT trial, which is gefitinib versus chemotherapy. First trial, which was RADIANT, shows that non-significant disease-free survival improvement. So this study was closed. The second was with gefitinib adjuvant CTO-NG study, which shows significant disease-free survival benefit, but it was not translated in overall survival. Just why we treat patients? It's very, very common question. We treat patients, first of all, because we want to improve overall survival and keeping in mind quality of life, of course. So this is a baseline characteristic of patients: male, age, smoking history, race. There is very nice distribution of this. Patients were distributed and stratified, randomized by two parameters as well, which I have to mention. First is exon 19 deletion, and the second is exon 21 1-point mutation, which is L858R. So this stratification was very good with adjuvant chemotherapy. Patients, 60% in each group received adjuvant chemotherapy, 14 not. So overall survival, patient with stage 2, stage 3A disease. Adjuvant osimertinib demonstrated statistically and clinically significant improvement in overall survival versus placebo in the primary population. And it was, after 5 years, 85 versus 73, 12%, which is huge difference after 5 years. We'll know a lot of trials. It was a well-known trial, Pacific trial, which shows 10-year overall survival benefit. It was magnificent trial, which was changing our practice. But Adaura's change practice, and I think this is a practice-changing trial which shows 12% improvement after 5 years, and hazard ratio was 0.49. So, for overall population was 88 versus 78 in placebo group, with hazard ratio the same 0.48. So this is slide which shows in which groups was the most benefit, and you can see that in all groups, in all patients, there was benefit favor for osimertinib versus placebo. Overall survival by disease stage 1B, stage 2, you see here really big differences. Especially I want to focus on the stage 3A. It is very, very interesting because 85% after 5 years for stage 3A, it's a huge achievement in non-small cell lung cancer. We know from historical data that it was 30%, 40%, and it was fantastic results, but you can see that 85% after 3 years for stage 3A non-small cell lung cancer. So the next is overall survival in patients with or without adjuvant chemotherapy. In overall population, with osimertinib, with placebo, shows the same results. I mean that adjuvant chemotherapy does not impact on survival, and despite of chemotherapy, the result was favor to osimertinib. Subsequent treatment is very, very interesting issue. Patients, you can see patients who progressed on osimertinib received anti-EGFR tyrosine kinase inhibitors on first metastatic setting, and patients also in placebo group received anti-EGFR treatment. Chemotherapy, radiotherapy, you see here how it was distributed. So safety summary there was the same as it was mentioned in Adaura previous trial. No new signals. The only which was published, it was a COVID infection in patient, and authors concluded that COVID was not related to this, and patient fully recovered from COVID, which was a new, new adverse event. And the conclusion in the Adaura primary analysis, adjuvant osimertinib demonstrated a statistically significant and clinically meaningful disease-free survival benefit versus placebo. For 1B, 3A non-small cell lung cancer, and disease-free survival as well was significantly improved with adjuvant osimertinib. This is the first study, as I mentioned, globally, which demonstrate both disease-free survival and overall survival benefit. And future consideration, we have a lot of questions which are open. Now we have one study which shows, which is investigated neoadjuvant osimertinib in stage 1A group. So the results are awaiting, and I think that in a couple of years we will get these results. Thank you for your attention. This is a new study which was published this year in New England Journal of Medicine. And I want to thank you once again, Kazakhstan, and all of us. I'm from Georgia, which is unfortunately still occupied 20% of Georgia by Russia, but Really, we love very much, and we are very hospitality country. And I know that many of you have been there, but you are all invited in Georgia. Enjoy Georgia, and we know friendship and hospitality as you. Thank you.
Thank you very much, Иванка. Спасибо большое. Коллеги, мы возвращаемся к интерактиву.
Thank you very much, Ivanka. And let's get back to interactive questions. Let us remind you the questions. I will help
Определение
the
EGFR
speaker.
мутации показано.
The first question.
4 варианты ответа.
EGFR mutation is recommended for patients with non-small cell lung cancer from 1B up to 3A stages after radical surgery. Answer B, patients with advanced unresectable stages of the non-small cell lung carcinoma. Answer C, with any form and stage of lung cancer, regardless of histological type of tumor. The answers A and B are correct. This is the D answer. It's interesting to know the first answer is 100% correct, because before the lecture it was 74% only. Thank you, dear audience. Second question. The recommended duration of osimertinib usage in adjuvant mode after radical surgery. A, 12 months, B, 36 months, C, 6 months, D, 24 months. We see positive dynamics in these answers. It was 70% less. And the correct answer is B, 36 months. For the second question. And third question is the situation. The case is patient is 26 years old, underwent radical surgery in volume, lower lobectomy on left, mediastinal LD. The post-operative stage is ST2A. ROG2, EGFR positive. What are your further recommendations? The answer is A, osimertinib in adjuvant mode for 3 years after radical surgery. I believe all three questions were answered perfectly. Is there any questions? Yes. Indira Mulatovna. Professor Omarova, the question about toxicity of treatment in Adaura, there were two subgroups of patients who got first chemotherapy and osimertinib, and another group got just osimertinib without chemotherapy. And my question is, chemotherapy in combination with osimertinib, did it have same toxicity or it was higher than in the group with osimertinib only?
So I will answer in English and then in Russian.
Yeah.
First of all, not combination. As I understand, you mean sequential. То есть это была не комбинация, а это было сначала химия и потом.
So it was chemotherapy and then osimertinib. It was not a combination. Yes, first chemotherapy and then osimertinib, and then compared with the group who got just chemotherapy.
On toxicity of osimertinib. То есть химиотерапия не влияла на токсичность osimertinib. То есть эти пациенты, которые получали
So those patients who got chemotherapy or who did not get chemotherapy, they had same toxicity, no changes. We know what kind of inhibitors, so it's manageable.
Менеджировать токсичность. То есть химиотерапия не влияла.
Оксана Владимировна, вопрос?
Да.
So toxicity did not impact. Thank you very much. My name is Oksana Vladimirovna. Thanks a lot for interesting presentation. Osimertinib in Kazakhstan is regularly applied, prescribed, and also there are prescriptions to use it in the neoadjuvant mode. Still, we know that the target medications are quite expensive for the first and for the third stage. What is your choice? For which patients you would prescribe neoadjuvant therapy with osimertinib? Take into consideration there are 3 different stages. It is prescribed here and there, but we live in a realistic world, and the details of the expensive medications are variable.
It's a very challenging question. Это очень трудно сейчас.
And it is difficult to answer right now because there are outcomes of the research and then depending upon your access to treatment. That is why stage 3A, those one which is the most risky. But if I will live in an ideal country, then without limitations, of course, this will be prescribed to all the groups because we have DFS and overall survival benefits. But under these circumstances, I would, based on reality, those patients with 3A, maybe stage 2. Thank you. Thank you very much. Maybe more questions? In ADAUR research, it was prescribed with normal GFR mutations. And what we can do with those patients with rare mutations? You mean resistant mutations? No, there are some so-called rare mutations, because in the prevalent lung cancer with the GFR drugs, if it is mutation 2021, then we can give them afatinib. That is the only drug available for rare mutations or cross-cutting mutations. So what we can do with the mutations like 858, not only them, ENCRC, various mutations. So the main thing I understood. And this is a very, very good question. But on the other hand, we understand that 20 mutation is a rare mutation.
A lot of trials are ongoing now. There are
a lot of trials ongoing for rare mutations. Today, we may say that it is a boom of rare mutation research. But now they pick up the main mutations, but we don't have data available for rare mutations. And this study is for zone 19 and 21 mutations only. Thank you, colleagues. Any more questions if you have them? No more questions. I want to thank the speaker. And now I would like to give the next speaker floor, Irina Lazarev, MD, Institute of Oncology, Asuta, Ashdod University Hospital, Israel. Please, the floor is yours. It looks like her microphone is muted.
First of all, scientific committee and organizing for inviting me to this very important meeting, and it's great pleasure to be of part of this knowledge, education, and friendly experience. My name is Irina Lazarev. I from Israel. I am medical oncology, and my specialization is thoracic oncology. Originally, I was asked to prepare my presentation in Russia, and yesterday I really enjoy and impressed of open live discussion and waterfall of question that you ask. So I decided to switch to Russian after our traditional survey. So I understand that I will start with our question. Okay, you have 3 tricky questions because really today we don't have a simple answer. Really, I don't want to check your knowledge, but to know your opinion in this subject. Okay, our first question, are you aware of any results of early stage lung cancer immunotherapy studies? So you have 4 options to answer. To read the options, or you don't need it? Okay. Our second question, do you consider it appropriate to use neoadjuvant chemoimmunotherapy for patients with early stage 1, stage 2 to 3B non-small lung cancer? And the third one, do you consider routine PD-L1 testing to be an important factor for choosing immunotherapy for patients with early stage non-small cell lung cancer? Okay, do we have results of this survey?
Excuse me, коллеги, минуты 2, мы хотим посмотреть.
Dear colleagues, just 2 minutes. We just want to check the answers for the first question. Do you know the results of immune therapy? Different answers, 48%, 26% and 26%. Next question.
Вопрос, считаете ли вы целесообразным использование неадъювантной иммунотерапии для
Second question is, do you consider it appropriate to use neoadjuvant immune chemotherapy for patients with the stage 2, 3 or 3B with a non-small cell lung cancer? The question number 3. Do you consider routine PD-L1 testing to be an important factor to choose immunotherapy for patients with early stage of non-small cell lung cancer? So the majority is answered A. We continue our lecture.
Еще раз я хочу представить вам презентацию на русском языке для удобства нашей.
So let me present in Russian for convenience, and I'm very much pleased to provide the results of the Keynote 671 randomized double-blind study of phase 3 pembrolizumab and placebo group with the platinum-based chemotherapy. As we may know, immune therapy was very successful for treatment, and then the second stage we started to research which way immune therapy can impact the early stage of the lung cancer. And probably you know there are several randomized studies showed that adjuvant and neoadjuvant approach give good results. And in some cases, still we see progression, and we would like to improve those results. And also recently, there were results published from the randomized studies durvalumab and neotorch, made in China, who studied the preoperative immune therapy when patients got immune chemotherapy before surgery and neoadjuvant therapy after surgery. It improved the overall survival and improved the pathological response. The Keynote 671 research had same question, which way the preoperative immune therapy can improve the results. There were patients resectable, decided by the Commission from 1 up to 3B stage. The 8th version of AGCC classification, and also the subroot patients and nodes and lateral nodes patients were eligible, and they should be in a good performance status and biopsy to be submitted in order to determine PDL. But this status was not obligatory to be included in the study. In neoadjuvant stage, the patients who got 1-to-1 treatment, they got 4 courses with a standard chemotherapy that was chosen basing on the histological type of a tumor, and then got chemotherapy. Not later than 20 weeks after chemotherapy, the surgery was made, and the study in the group of pembrolizumab took 1 year, and another group was placebo. The stratification factors is PDL status, the disease status, and histological subtype, and the region of the patient where he lived. The end point of this research determined the overall survival and progression-free survival and main pathological response. From the point of view of statistics, the results we provided today is the first interim analysis, and the latest data included here was done in July 2022. 383 events were there, and increase was into 5 months. In this table, we may see the distribution of patients according to the stages of treatment. In the distribution for monitoring, they were average 25 months, and 87% went through randomization, and around 74% finished neoadjuvant course of pembrolizumab or with placebo. Very interesting data. 82% of patients in a group of pembrolizumab and 79% in placebo group went through the surgery, and only 73% in a group of pembrolizumab and 67% in placebo group got at least 1 treatment in neoadjuvant phase. In this table, we see main baseline characteristics of patients, well balanced. The majority are men participated in this study, and there were more patients with non-small cell lung carcinoma, and the majority of patients were from the 3A stage. This is the main stage of that disease, and also there were patients with non-small cell lung carcinoma with nodes, lympholateral nodes. And PDL status was not obligatory to be eligible for this study, but it was important to check that. And distribution of PDL status, 1/3 with higher grade, 1/3 with medium grade, and 1/3 with low grade. This is important for statistical purposes. In the group of pembrolizumab, they got R0 resection, and in placebo group, pity to say, as the minority got the complete resection. The primary endpoints we see on the curve of Kaplan-Meier, and there is a clinical significance in a group of pembrolizumab, improve of the overall survival. And the significance is 0.58, means 42%. The progression-free survival proved by this experiment. It's interesting to know that in almost all the subgroups there was the benefit from the treatment, and small groups, subgroups like non-smokers, patients with a second phase, and PDL negative patients, their improve was not statistically significant. The group analysis showed that the groups are quite small, so that's why the analysis should be done carefully. The overall survival was determined by primary endpoints, but for now it has not reached the significance, but a good value 0.72, and very soon we will see the improvement in overall survival. Also, good results in major pathological response, and we see that less than 10% of active malignant cells left over. And also from the point of view of complete pathological response, 4 times better results comparing to placebo group. Another interesting analysis, the ratio between the event-free survival and the status PCR. So the group of event-free survival showed better results, and they have not reached the complete pathological response, and still those who got treatment had better results comparing to those who did not, and the results are comparable. And then it's important to know about toxicity, means what is the price paid by our patients. And the toxicity of the stage 3, 4, and 5 was quite high, but mainly it was because of chemotherapy. And in case we see the effect of the regular immune therapy, around 5% had severe adverse events, and they stopped the side effects therapy because of side effects. And very frequent side effects are relevant for chemotherapy, changes in the blood samples. And regarding the immune-related adverse events, the RAC classical adverse events, no new signals. So to summarize, the neoadjuvant pembrolizumab together with chemotherapy with the consequent radical surgery, and then with adjuvant therapy with pembrolizumab provided statistically reliable and clinically significant improvement of the event-free survival comparing to the neoadjuvant chemotherapy and radical surgery. The results of overall survival currently in the first interim analysis, that data is not ready, and the list of adverse events is conventional. This data is demonstrating the importance of perioperative approach, and probably it will be our future for treatment. And of course, the investigators are thanking the participants of this trial, their families, and 189 centers all over the world who participated in this study. This study was done together with an article published in the New England Journal of Medicine. So again, it proves the importance of the study. And It was presented in the Best of ASCO summit. So this study is quite ready to apply in real practice, and it repeats our previous knowledge. And to my point of view, the application of immune therapy in the early stage of lung cancer is a standardized treatment. There is a list of permitted medications, 2 medications in the adjuvant and other ones in the neoadjuvant therapy, and usage of immune therapy is efficient in perioperative period. Regarding the main points of this study, it seems to me that there is an important revolutionary study called Checkmate 816. So there were 3 courses of nivolumab basing on the histological classification. It gave a good improve in complete pathological response. And for us, it's important to monitor the survival graph. And after 3 years update, we see the improve in the 3 years survival who got just 3 courses of neoadjuvant chemotherapy. And the results of overall survival are not ready yet, but it's very promising. The second important research for the early stage of lung cancer is called Keynote 091-Pearls, application of pembrolizumab during 1 year. The patients with the early stage of lung cancer, 1B up to 3A, according to the 7th version of classification, should get the radical surgery. And chemotherapy was not obligatory. That's why only 80% got neoadjuvant chemotherapy, and then they were randomized to use the pembrolizumab to take it during 1 year. The primary endpoint was the progression-free survival without dependence on PDL, and it was positive. The second primary endpoint was to check invasive disease-free survival. And here, the result was not positive. And it was not usual for the lung cancers. We used to see a classical link between the expression of PD-L1 and results of a treatment. And we have heard about that yesterday regarding the breast cancer, when PDL is impacting the metastatic phase of cancer, and there is no correlation with initial stage. So probably there is different biology in those diseases. But this medication was permitted to use without dependence on PDL status. Another study is IMpower 010, the application of atezolizumab in adjuvant regimen. Here is the update on overall survival. This study was a positive one, and last year we saw the additional analysis providing overall survival, especially in PD-L1 group positive. That was a clinical significance in approval of overall survival. Then we ask ourselves, what shall we do next with all that? Shall we use it in neoadjuvant? Shall we use it in the adjuvant or in perioperative regimen? Currently, there is no definite answer. Shall we use it mainly in neoadjuvant or adjuvant or perioperative? And the study Keynote 671 showed good results in overall survival. And I believe that the tactics will be used for the future. But shall we use neoadjuvant treatment after adjuvant treatment? Pity to say we don't have direct comparison because it will be very expensive study. Our understanding we can make from the indirect comparison, and most probable the indirect free survival will give us good knowledge. And the patient who got the pathological response, but overall survival was better, it's related to the neoadjuvant treatment. Also, it's important to know about the biomarkers that would prove the sensitivity to medications. Currently, PD-L1 status is extremely important to understand the treatment tactics, but pituitary does not provide the direct correlation with treatment. An additional biomarker that we may use is the complete pathological response, but it does not provide complete answer. A patient who reached a complete pathological response, probably we should stop that treatment. Another side of that, in case patient does not provide good pathological response, and after radical surgery we do not see pathomorphosis, which way neoadjuvant treatment can improve that therapy and status? Most probable, to my point of view, neoadjuvant treatment is still important for some groups of patients, and we should take into consideration the cost of treatment and adverse events, and the financial costs is quite high. And the time is very consumable. Daily, they should come for infusions. And also, regarding toxicity, even there is a low toxicity, like rash or the thyroid function dysfunction, it can change his life quality. In conclusion, I may say that Keynote 671 and other perioperative studies in the future probably will change our treatment tactics and will become conventional treatments. And each patient with early stage of lung cancer should be subject for the multidisciplinary committee in each individual case. And an additional effect of adjuvant therapy after neoadjuvant therapy still should be followed up, and additional biomarkers are important to be checked. In the nearest future, we will have an opportunity to improve our selection in order to customize treatment for each patient with early stage of lung cancer. Thank you for your attention. Thank you very much, Irina, for your interesting information. Dear colleagues, once again, let me remind you, please scan QR code, and there is a comment. Those questions were drafted by a speaker for discussion. Each answer can be correct, so it's up to you to discuss, to ask, to argue your answer. And within the frames of this discussion, we can get an answer. Probably not all questions are relevant to your region, or maybe to answer one question, all answers are relevant. I see that in our audience we see many clinical oncologists from different regions. Please comment while answering the questions and defend your opinion. The first question. Do you know any results of the immune therapy treatment in early lung cancer treatment? The first answer is yes, there are enough to be introduced into routine clinical practice. The answer B, yes. However, they are not enough for implementation into routine clinical practice. The answer C, no, I would like to get acquainted with that. Answer D, immunotherapy is in principle not applicable for early lung cancer. The second question, do you consider it appropriate to use neoadjuvant immune chemotherapy for patients with a stage 2, 3, or 3B with non-small cell lung cancer? The answer A, no. There is not enough data on the benefits of this approach. The answer B, yes, for a certain category of patients with stages 2, 3A, or 3B. The answer C, yes, for all patients with stages 2, 3A or 3B, or answer D, I'm not engaged in systemic therapy of lung cancer. While answering, you can argue and defend your position. Question number 3. Do you consider routine PD-L1 testing to be an appropriate and important factor to choose immune therapy for patients with early stage of non-small cell lung cancer? The answer A, yes. Studies confirmed the relationship between the effectiveness of immunotherapy and the level of PD-L1 expression. The answer B, no, there are studies demonstrating the efficiency of immunotherapy regardless of PD-L1 expression. And answer C, there are conflicting data, additional research is needed. And answer D, I'm not familiar enough with this topic. The majority answered A and B. The answer A is that the results of early-stage lung cancer immunotherapy studies are not enough. Regarding the immunotherapy application in early stage, it's not for all the groups of patients. It's done based on status of PD-L1, and some patients are suitable for that treatment. I don't know, maybe it's different in different countries. Any other comments from the audience? The second question. Do you consider it appropriate to use neoadjuvant immune chemotherapy for patients with stage 2, 3, or 3B with non-small cell lung cancer? So the answer B, 76% of answers. I agree completely. I would use the answer B as well. The question 3. Do you believe that routine PD-L1 testing is an appropriate and important factor to choose immune therapy for patients with early stage of non-small cell lung cancer? 59% of respondents chosen answer A. So, A, yes, studies confirm the relationship between the efficiency of immunotherapy and the level of PD-L1 expression. We would like to know the opinion of those who chosen the answer B. I believe this is an important component. The patients with the high PD-L1 expression can get more efficient result with the neoadjuvant therapy. We see overall survival improve in the group with the high expression of PD-L1. The patients with the low PD-L1 expression, that data is not available, but that data is important to choose the type of treatment. Any other questions from the audience?
My question regards pseudoprogression. То есть у нас в Грузии
in Georgia, we have big experience to use immune therapy because there is a big number of clinical trials made, and very frequent we see the false progression before or after immune therapy. When we perform neoadjuvant chemotherapy to our patients, and
когда есть doubtful resectable tumor, мы хотим, чтобы опухоль перешла в резектабельную.
So this way we would like to make a tumor to become resectable, but here it's vice versa with radiology. If in this study there were patients where there was no radical surgery because of false progression, and if it impacts
overall survival and results of this trial. Спасибо.
Thank you very much for your question, a very interesting one. Let me highlight that in our practice, relatively, we have very small level of the false progression, and we use computer tomography during 6 weeks, and it enables us to understand, was that the false progression in treatment? And regarding the neoadjuvant treatment, almost no false progression, or at least it was not reported. It's important to know there is a discrepancy between the response that we see in computer tomography and in real life in radical surgery. So the radiation response is coming later. And sometimes we see there is a shrinkage in tumor, but in computer tomography we don't see that. You are completely correct that there is quite a percentage of patients who progressed or could not go through the next stage of treatment, and selection of the patients for neoadjuvant treatment should be very, very careful. Initially, those patients should be resectable in order to be eligible for neoadjuvant therapy. So theoretically, we can make a surgery, and then we want to improve the data. These are the minimum changes, and they're still very important between resectable and non-resectable. And being a pathologist, let me comment as well to continue yesterday's topic of the breast cancer. We have no limitations to test. It does not depend on the stage of the non-small cell lung cancer, but we don't have the prescription for the early stages. It's interesting to follow the statistics, to compare, and it will be nice to continue it in the clinical trials. Pity to say we don't have the clinical trials for early stages. Thank you. Thank you, Elvira Bulatovna. Thanks a lot. Very interesting review presentation, overview presentation. In case you study in a routine way all the drivers, which way it impacts the neoadjuvant therapy, because we know EGFR, ELK, all positive forms, they are less sensitive for immune therapy. And secondly, during ASCO, we discussed with colleagues, and there is lots of data provided regarding the small and non-small care for smokers and non-smokers. And what is your experience in Israel? How often you use combination or monotherapy, but not in drivers? Thank you very much for your question. Regarding PDL expression and regarding genetic research, this is an obligatory prerequisite for our patient. The patients can get a permit to use neoadjuvant or immune therapy in case they have no mutation, especially such a mutation described in our presentation regarding neoadjuvant imatinib. If he is resectable, so preferable is to make a resection and then to provide neoadjuvant treatment. Also in Israel, we have clinics to research patients who are non-resectable, and they get imatinib, and they get either surgery or immunotherapy. Regarding the mutation ALK, like many others, we don't know what to do with such results. And most probably, if it's just on the age, I would prescribe systematic treatment or to make a resection, depending on the mutation ALK. Regarding metastatic disease, I agree with you. This is very important to perform correct selection of patients. So the patients with a high PD-L1 expression, for them we prescribe therapy except for the smokers. And we provide short combination. And in case we start immune chemotherapy and patient feels bad, we can stop earlier some components of chemotherapy, but the primary emission of autogens plays the important role in order to work with the immune system. One more question. In this research, there were more than 40% of patients with small squamous cell carcinoma. And is there any difference in those without relapse and overall survival? Ekaterina is representing Merck company who are promoting medication in Republic of Kazakhstan. And last month, Merck recalled the registration for patients with squamous cancer. Yes, there were some differences, discrepancies.
Specifically, in this event-free surveillance studies, we have equal results. Operative intervention is very effective, irrespective of histology data. In the research, you extended expression also on immune cells. I didn't get the question, I'm sorry. Expression was only on cells or in immune cells as well? The research was done on initial primary biopsy, but whether we have to do this expression on immune cells, this is not obvious. It usually goes depending upon the drug. Every researcher has its own standards and recommendations for use this or another drug based on immunohistochemistry data. And then we can determine further treatment strategy. Thank you, Irene. It was a very lively discussion indeed. And finally, metastatic lung cancer, donor carcinoma, no driver, mutation PDA 0, no expression, and in case of mutation, load TNB. Based on your practice, would you recommend immunotherapy just based on TNB? For instance, in our case, it is 14. Yes, we got TNB results. It goes automatically in our settings, but unfortunately, no A-TNB correlation and immune response clearly. That is why I would suggest combined chemoimmune therapy, maybe not datoranilizumab, but triple immune therapy, because there we will have more link with TNB. Thank you. Indira Milatovna. No mic. Mic, please. Kaldegul, I think we can check microsatellite stability. If microsatellite stability is tested, then I think it will be an indication for immunotherapy. Thank you again, Irina, for your very interesting presentation. It was very good and
Уважаемые
interesting,
участники
lively
форума,
discussion indeed.
сегодня в нашей секции
Distinguished
прозвучало
participants, today
3 очень
in our
прекрасных
session we
доклада,
had 3
очень
wonderful
таких
presentations,
информативных.
very
Вот.
informative
Давайте еще раз
indeed.
поблагодарим наших
And let us
спикеров.
once again thank all our
Также
speakers in this
хотелось
session. Also, I
поблагодарить
would like to thank
нашу аудиторию,
our
которая
audience,
показала, что в
which
течение одного
demonstrates
10-15
that
минут доклада
within
она
10-15
очень внимательно слушала наших
presentations
спикеров и, в принципе, по
absorbed
динамике
all
ответов можно
information
сказать, что
given by the speakers
быстро обучаемые.
based
Так
on
что
the
большое спасибо
dynamics
нашей
of
аудитории
your responses.
за
The learning
проявленный
curve is
интерес,
so
за проявленный
dramatic
интерес.
in this
На
audience.
этом
Once
позвольте
again, I want to
закончить. И
thank you
сейчас
for your involvement. With this,
всем
we're
еще раз
finishing
спасибо.
our session, and now we have lunch.
Құрметті қонақтар, дәл қазір сіздерді түскі асқа өтулеріңізді сұраймыз. Түскі ас қонақ үйдің бас ғимаратында өтетін болады.
Dear guests, now we kindly invite you to lunch, which will be held in the main building of the hotel.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологий производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. Быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. CAS-CS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. to celebrate 125 years, to celebrate all of us, to celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда – индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более $100 миллионов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. Быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение, положительно влияющее на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization, and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with the heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. CAS-CS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift. Life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более 100 миллионов долларов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.
Выбирая современную терапию распространенного рака молочной железы, онколог продлевает жизненный путь своих пациентов, чтобы они могли быть в жизни своих самых близких еще 5 лет и дольше. Быть рядом еще целых 5 лет и дольше. Подарите пациентам это время. Выбирайте лечение положительно влияющие на общую выживаемость. Продлите их путь.
Hello, dear users. In this video, you will learn about the KazCS mobile application. Next, we will tell you how to use this application and what features it provides. The application is available for download in the App Store and Google Play Market. To use the application, you need to complete the registration procedure. In the window that opens, you need to enter your registration data, such as email address, mobile phone, last name and first name, city, organization and position. For security purposes, you must create your own unique password containing at least 9 characters. After registering, you will be taken to the main page of the application, which consists of the following sections: upcoming conferences, past conferences, and the other resources section. In order to take part in the upcoming conference, you need to click on the banner you are interested in, and in the window that opens, confirm your participation by clicking the Participate button. If you closed the registration offer and later decided to join the conference, then when you click on the conference banner again, you need to click on the button with a heart in the upper right corner of the screen. By going to the conference you are interested in, you can see the list of speakers and event organizers, as well as find out of the number of participants. In the speakers section, you can find out date and time of the speech of the specialist you are interested in. You can get acquainted with the conference program when choosing the day of the conference and specific hall. Also, by clicking on the video camera icon, you can go to the online broadcast of the selected hall. When you return to the main page, at the bottom of the screen you will see a set of icons which we will discuss in more detail. In the icon with hearts, you will find a list of conferences in which you are already participating. After clicking on the conference window, you will see a section with a personal QR code by which you can attend the conference in person. In the icon with doctor, you can find the necessary specialist, information about him, and contact him in a way convenient for you, via instant messengers, social networks, email, or by phone number. In the icon with document, there is a current news feed. By clicking on the profile icon, you will enter your personal account, where you can add or edit information about yourself, which will be displayed when searching for your profile in the specialist section. Here you can edit profile photos, links to social networks and instant messengers, as well as block access to them. In the profile section, you will be able to change the language and the ability to delete your account. KazCS application version is updated automatically. Turn on the auto-update feature in your mobile phone settings. We hope that this information was useful for you and the experience of using our application will be simple and convenient for you. Thank you for your attention.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
клиникалық ғылыми симпозиумға модераторлық ету үшін подиумға өтулеріңізді өтініп сұраймыз.
Dear Oksana Shatkovskaya, Indira Umarova, we kindly ask you to occupy your seats for the moderation of the Clinical Sciences Symposium Lung Cancer.
Извините, пожалуйста, микрофон не был включен. Мы продолжаем нашу сессию.
Dear ladies and gentlemen,
По раку легкого.
our finalizing session dedicated to the metastatic lung cancer. Thank you for coming online and here in the audience. Those who are with us online as well. This session will continue the previous topic, lung cancer treatment. And today, let me invite the first speaker, Nia Sharihadze, the professor, head of Department of Clinical Oncology, Mardarishvili Medical Center in Tbilisi, Georgia.
Аплодисменты. Начинаем, коллеги, с тестирования.
Добрый день, дорогие коллеги.
Good day, dear colleagues.
Good afternoon, dear colleagues. So it's a great pleasure to be a part of the Best of ASCO in Kazakhstan 2023. It's a great honor, and I am very appreciated that you trust us and invite us to present very important and daily practice changing presentations today. Thank you so much. So now we will start with the interactive questions. First question is, I can read it in Russian.
The first question is, which patients are recommended to determine ALK mutation in routine practice? The first answer is A, all patients with lung cancer, regardless of the histological type of tumor. B, a young patient with lung cancer at the time of progression after complex therapy. Answer C, smokers with a long history with a common form of squamous cell carcinoma of the lung. Answer D, all patients with the MNSCLC, metastatic non-small cell lung cancer, especially with adenocarcinoma. Next question is, ALK diagnostics was performed using IHC, FISH diagnostics, RNA sequencing. All answers are correct. The third question is, the patient is 52 years old, operation was performed, thoracoscopic resection of the upper lobe of the right lung. The post-operative stage is T1 and XM1. ST4, metastases are in brain, lesion 1 and solitary. Histology is adenocarcinoma, ALK plus, EFGR not detected, PD-L1 15%. The best treatment option for this patient is answer A, radiosurgical treatment of metastase brain lesion. Then the courses of chemoimmune therapy according to the scheme: pemetrexed, carboplatinum and pembrolizumab, up to 4 courses followed by supportive immunotherapy until progression. Answer B, targeted therapy with ALK inhibitors, given the presence of the metastasis, brain damage, and in this case, preferred option is ALK inhibitors of the second generation, like ceritinib, alectinib, brigatinib. So the answers for the first question: D, for all the patients with non-MNS-CLC, the answer is D. The second question. So in the previous question, all the options are correct. So for the second question, ALK diagnostics was performed using IHC, FISH diagnostics, RNA sequencing, or all the answers are correct. So we will double check the answers after the presentation.
So I am a medical oncologist, and we are, unfortunately, we are treating most of type of cancers in Georgia. So we do not have such privilege to be very focused on one or two type of cancers. So we try to be up to date in all type of cancers. So my presentation today is related with explore ALK, alectinib activity in patients with ALK-positive metastatic non-small cell lung cancer. It's a national real-world analysis from French group of lung cancer treatment group. Okay, here. So, background and objectives of this trial. This was the poster in ASCO 2023, and we well know that real data is very important to change our everyday clinical practice, because despite our information and daily practice are based on clinical trials data, we need to be handle the in everyday practice. So, background is alectinib is a standard of care option in advanced ALK rearrangement non-small cell lung cancer with efficacy established based on phase 3 trials in first line and beyond. First such trial was ALEX trial, evaluating alectinib compared with crizotinib, including more than 50% of the Caucasians, and performance status of this patient was 0 from 2, so a little bit symptomatic patients as well, with 42% of asymptomatic brain metastasis. We well know that main target organ for lung cancer is a brain, and more difficult to manage such patients if they are advanced stage, of course. And these trials showed that median PFS was 34.9 months, and median overall survival was not reached. It's pretty impressive data that we know that stage 4 lung cancer overall survival 5 years is less than about the 15%, so these data are very impressive. In this two another randomized studies, ALLURE, evaluating alectinib versus chemo post-crizotinib, median PFS was 10.9%, and in ALTO3 trial, evaluating alectinib versus brigatinib. Brigatinib is a second generation of the ALK inhibitor. After progression on crizotinib, median PFS was 19.2 months, and all are clinically significant data. There are few efficacy data in unselected population. That's why French group make decision to perform it in real world setting. So objective of the studies was to evaluate efficacy in real world. So method was explore ALK in French non-interventional multi-center study. It was prospective study, constituted of two parts of two cohorts, including ALK positive non-small cell lung patients. First cohort, which I will present today, including patients treated with alectinib, since its marketing authorization in France was approved from January 2018 until March 2020. So all ALK positive advanced non-small cell lung cancer patients initiating alectinib, whatever the line, during this period were included. So there were the first line, second, third, and beyond. So cohort B, including patients treated with next generation ALK inhibitors, it's an investigator's choice. It's ongoing now, and in first line, alectinib, brigatinib, or lorlatinib, treatment-naive patients from March 2020. So results presented here are the results from cohort 1. So patient characterizations, alectinib duration of the treatment, progressive-free survival assessed locally, overall survival, prescription line alectinib, and presence of the brain metastasis and brain overall response rate. So as I already told, cohort A, including histo or cytologically confirmed advanced non-small cell lung cancer with ALK rearrangement. Patients having initiated alectinib treatment regardless of the treatment line between 2018 to 2020. Age was regularly more than 18 years old, and patient with brain metastasis treated or untreated, symptomatic, not or are all included. So endpoint I already prescribed, and cohort B, which are already ongoing, was histo and cytologically confirmed advanced non-small cell lung cancer with ALK rearrangement, and it's important that patients were naive of treatment. Age more than 80 years old, and decision of the treatment was TKI or physician's choice for any line of the treatment as long as drug has approved in the obtaining reimbursement. So, results. Baseline patients' characterization is 223 patients among 33 centers from French. ALK characterization was performed by immunohistochemistry in 130 patients and by FISH in 130 patients. Only five patients had RNA sequencing analysis. So ALK fusion partner evaluated in 29 patients, and it was as regular EMLA fusion. DCTN1, it's a rare, and it was discovered in one patient, and concurrently mutations evaluated in 20 patients, and it was 3 KRAS, 2 PEAK, and 6 TP53, and 9 others. So alectinib was initiating as a first-line treatment in 190 patients, 49 patients in second line, 25, 12, and 13, third, fourth, and beyond lines respectively. So we well know that ALK fusion evaluation standard is a FISH method. Of course, we use the immunohistochemistry as well, but ctRNA or ctDNA sequencing analysis is the best, but all three have their challenges, benefit, and some, of course, the false negativity and false positivity. When we discussed with my colleagues from Israel, they told us that despite that they do not have any reimbursement problems, when they evaluated 3 or 4 mutation driven, they can perform the PCR method, but if they evaluated more than 4 genes, so they prefer to perform the CT or ctDNA or ctRNA, of course. Patients' characteristics was the median age is 59, and we all well aware that ALK mutation is more frequent in non-smokers or light smokers or former smokers which or quit smoking many years ago. young age, about median ages is 59, 50 or below, and important the gender, it's not affect on the incidence of the ALK mutations. So that's why here was all type of patients, never smokers, current or former smokers. Histology 95% was the adenocarcinoma, which are more common, of course. Squamous was 1.8%, and other was like the non-otherwise specified was 3.1%. Actual stage was 3B, which are borderline with surgery or perform or not to perform surgery, and stage 4, which was 95%. So performance status was more or less distributed in the same manner, and most patients was with good performance status. Number of metastatic sites, there were oligometastatic disease, 2, 3 or more sites. And I would like to mention that here was, as I already told you, CNS problems, CNS metastatic patients, about 30%. And it's important to take in account how efficacy is really in real world in brain metastatic disease. So first results, alectinib efficacy in the first line. After median follow-up, 33.7 months, it was 28, so locally evaluated PFS. And here we have the alectinib efficacy in the first line, objective response rate. So it's pretty impressive, 79%, and we know that in ALEX trial, JALEX trial, and in the other trials, it's about 82. So it's correlated with the clinical trial data as well. Complete response, 21%. It's very impressive because in stage 4 lung cancer with limited overall survival to achieve the complete response, it's pretty impressive. Pity that such patients are not so much, because we will have good response on the treatment. Partial response is 58%, and duration of clinical responses was 96%. And median duration of response was 27 months. So it means that patients feels fine during more than 2 years. So median PFS was 28 months, 12 months rate was 70%, 24, 49, and 36 months, 38%. Median overall survival was not reached, and 3 years overall survival, 72%. So, and most impressive, best intracranial response, complete response was 26%, and I would like to keep in mind this data. We need to use it on the answers of our questions. And partial response is 46%, and stabilization 23%. Alectinib efficacy in the first line, so it's a summary. After median follow-up, 33 months, the median locally evaluated PFS was 28.1 months and 26.9 months respectively with duration of treatment. Median overall survival was not reached, and 3 years overall survival rate was 72%. The locally advanced PFS was significantly different on whether or not the patient has brain metastasis. And I kindly remind you, and 29% was complete response in the brain metastasis. So second line and beyond, alectinib efficacy was pretty impressive as well. PFS was 28.5 months. With cerebral metastasis was 30.9, and without cerebral metastasis was 60.9. So overall survival not reached, and 3 years overall survival is 70.1 months. So it's not big difference between the second line and the first line treatment as well. And we know that all next line treatments have less efficacy. But here, alectinib still keep the effective results. So alectinib efficacy in second line and beyond, duration of the treatment was 20.6 months, PFS was 90.6, overall survival not reached, and 3-year overall survival 70.6 months. Duration of the treatment on fourth and fifth and more lines was less, 18.7 months and 14.7 months respectively. PFS was 17.4 and 11.7, and overall survival, of course, was less, 35.1 and 40.1 months. So it's a little bit strange that when we use the alectinib in the fifth line, we have more overall survival than we have in fourth line. But I think that we need to keep in mind, and I hope that French group will divide it in and go deeply and show us why this happened in this data. Explanation of the resistance and perspectives. Of course, unfortunately, we know that despite of first line, first generation, second generation, or third generation ALK inhibitors, unfortunately, we have somehow resistance. This resistance may divide it local to ALK rearrangement mutation difference. We have the secondary resistance, and it have a lot of reasons, so I don't tell now it's here. But analysis of molecular routine data collected for this cohort, they are still ongoing. That this is a new clinical trials to evaluate what's happened, what kind of mutations are appeared, how it's strange, and what's a reason. Maybe it's a coexisting of another gene mutations, and so we will wait until analyzing of this data. Oops. It's me? Okay. About the tolerance. The poster did not give us the detailed information about the tolerance and adverse events, but they told us that no difference compared with the previous clinical trials. So 33 patients had a grade 3 adverse events resulting in a temporary interruption of the treatment. They need some permanent discontinuation or dose reduction. So, and most of clinical trials, previous clinical trials, tell us that tolerability of this alectinib is pretty fine, so no necessity to high percentage permanent discontinuation of the treatment. And conclusion, in this large real-world group cohort of unselected advanced ALK-positive non-small cell lung cancer patients, alectinib initiated in first line provides similar efficacy and safety results as obtained in phase 3 clinical trials. So this is funded by Roche, and it's conducted in French, so there is 33 clinical centers in France. Thank you so much. Now we can go back to our questions. So, and I have my own comments on these questions to share with you our Georgian experience, how we manage such patients locally in Georgia. So first question was, maybe in Russian,
which patients are recommended to check ALK mutation? The first option to all the patients Doesn't matter what type of histology in the tumor they have. To the young patients with lung cancer at the time of progression after complex therapy, answer C, smokers with a long history with a common form of squamous cell carcinoma of the lung. Answer D, all patients with MNSCLC, especially with adenocarcinoma. Second question, ALK diagnostics was performed using what? The third question is the case. The patient is 52 years old. The surgery was performed, a thoracoscopic resection of upper lobe of the right lung. The post-operative stage is T1, NXM1. Stage 4, metastase is in brain, one solitary. Histology is adenocarcinoma, ALK plus, EGFR not detected, PD-L1 15%. The best treatment option for this patient is answer A, radiosurgical treatment of the brain metastasis, then the courses of chemoimmune therapy according to the scheme, pemetrexed, carboplatinum, pembrolizumab, up to 4 courses, followed by supportive immune therapy until progression. And what are the results for the answers? Let me comment the answers. 77% answered D for the first question, means all patients with metastatic non-small cell lung cancer. But you should take into consideration that mainly adenocarcinoma is characterized by ALK mutation. Different authors are interpreting that differently. From 3 up to 7% are mostly determined in the non-smokers, men, women, young. No strong impact on the results. So looks like everybody should be tested for that, because you had such opportunity. And since in Georgia patients are paying themselves, that's why we do our best to take into consideration everything. So should they be young or smokers or light smokers? Of course, if there is a possibility, this is included into the routine ALK testing. Like Nia said, yes, we are limited with the life reality, but everybody should test it for ALK mutation. There are other people who answer differently, take into consideration other life issues. So, still, everybody should be tested for that. Second question. So, in general, all answers are correct. But all over the world, the golden standard is immunohistochemistry. And if you have an opportunity to make the next generation sequencing, this is the best. Yes, the correct answer is D. All answers are correct. But other answers are also correct. I wanted to ask you, in Georgia, you make fish and RNA sequencing, because determining fish with the immunohistochemistry, it is available here. Could you please pass the microphone to Elvira Bulatovna? Immunohistochemistry is absolutely validated protocol D5F3 clone. The stainer is Mentana platform. no issues with that. We have other colleagues, pathologists. There was a small problem in detection when we saw strange staining. But later on, we discussed in Zoom with colleagues from US, and it looks like we have solved that issue. But my question is, still, we don't make ILK and EGFR. We don't make it simultaneously. We make it consequently. Only when we determine ALK mutation, only then. We check and exclude other mutations. Since our patients are paying themselves, we take care on their costs. We make ALK only afterwards. But if we can make the next generation sequencing and the FMI, then we have an opportunity to make the complete panel, including tumor board. So if we have an opportunity, we do all. But the main is to maintain standard testing. Regarding the multifaceted genome profiling, it is included as an option of possible diagnostics. And together with the Roche company, we implement a project on the multifaceted profiling. There is a possibility to send patients with datations for testing. And still, there is a guaranteed social package, but it does not include it because this is a very expensive method. Not each country can afford themselves to do that all. So we make it consequently EGFR and then ALK and then PDL we make. And of course, multifaceted genome sequencing provides the full picture. We see the profile of a patient and we see the prospects of treatment and we see the sensitivity for target medications, for immune medications, and we get a full conclusion. Also, we wanted to comment the next question. 96% answered B. Let me comment others who answered the correct answer A. So the correct answer is B. But A, what we took into consideration during latest 10 years. First, we thought that EGFR is target. Then we thought immune therapy can cover all. When we thought that target therapy can work but not, and we found out, basing on data, that mutation and non-mutation is not responding well for immune therapy. Currently, ALK inhibitors, they are the best, they are the first line. So for us, for the future, we can keep chemotherapy, but we will see which way to combine it with immune therapy. I can agree completely with you. Why 96% answered about ALK inhibitors? Maybe we can check other mutations, but regarding patients with ALK mutations, always for them we provide ALK inhibitors. If there are EGFR mutation or ALK mutation, we don't check PDL. We check mutations and we prescribe medications against mutations. This is the golden rule. Yeah, it's a standard. Why I'm voting for the next generation sequencing? Because deeper we develop it, better we see that they are competing gene mutations, they cohabit. together, and we don't know what is the trigger mechanism that we should inhibit first of all, and which we should inhibit secondly. Probably I'm stepping away from my topic, but we know that Kirase is very actual, but we got protolasib for the second line, and then we will see what kind of results we provide. Probably it will be the first line, but in the real data there was a K mutation and a ALK mutation, and then we will see what to inhibit first of all, ALK or Kirase. I wanted to ask the correct answer for the third question. Yes, of course, there should be therapy with ALK inhibitors of third generation, second generation. Ceritinib, alectinib, brigatinib. What would be your choice? Of course, we would choose alectinib. In order to explain why, because we train patients and we try to keep their condition not only to treat them, but also to keep the performance status. Take into consideration the adverse events. I don't want to say anything about ceritinib, but it is less efficient than alectinib and brigatinib. But comparing adverse events, we should choose individually. Me personally, I would prefer alectinib, providing more tolerant adverse event. Regarding the tolerance, more tolerable adverse events. In the French study, there was no data about toxicity. For all ALK inhibitors, there is more or less similar profile of toxicity. Some part of patients got crizotinib as a first line. Would they have cumulative toxicity? Means patient got one medication, then changed to alectinib. Would he have an accumulative toxicity? I think no, because mainly with alectinib there is a liver function elevation. For crizotinib, there is another toxicity profile. When we start second-line treatment, first we try to make them recover from the first line in advance. Why I asked this question? Because it happens our patients are treated like that. Comparing other medications, alectinib is having softer toxicity profile. This medication can be prescribed even for patients with the kidney failure and liver failure of the light and moderate insufficiency according to the child Pew. This is a very severe category of patients. Any other questions? I have a question. You spoke about Kirase mutation. I wanted to ask about HER2 mutation. It is also in the second line. Yesterday we reported, and my colleagues reported, that trastuzumab, rexumab, is relevant for breast cancer and for the non-small cell lung carcinoma. So this is for the second line. The first line is treated conventionally. Can we prescribe trastuzumab still, old style? I cannot say for sure, but do we treat the cancer of intestines with trastuzumab? We prescribe the colon cancer with trastuzumab. I think, yes, we can prescribe trastuzumab, but I agree with you completely. Thank you very much for your in-depth lecture. It is very interesting. Dear colleagues, now let me pass the floor to Natya Yohadze, who is the head of clinical oncology department in American Hospital, Tbilisi, Georgia. Natya Yohadze, the floor is yours. This is the second phase of randomized study of maintenance with the atezolizumab A versus atezolizumab together with talazoparib AT in patients with SLFN11 positive extensive stage of the small cell lung cancer, ES-SCLC. So, traditionally, during 50 years, the main option for the small cell lung carcinoma there was platinum cetapazid, and nothing was changed during many years. And now it's very optimistic to know about the new tendencies in treatment. Regarding the answers,
I cannot hesitate not to thank again for letting us to be here, for your hospitality and friendship. This is very important, what we feel here. So thank you very much again. The topic of my discussion today is small cell lung cancer, and I completely agree that small cell lung cancer is a very challenging disease in these terms because we don't have any predictive biomarkers here. We don't have predictive biomarkers that are reliable for us because this is very heterogeneous disease and these biomarkers are not expressed consistently. And this is a very important issue. And every single study that gives us any hope in this field is really very important. So thank you very much. No, I want to start my first slide, yeah. Мы сделаем тестирование. So, I am pleased to present today the SWOG S9029 phase 2 randomized study of maintenance atezolizumab versus atezolizumab plus talazoparib in a patient with SLFN11 positive extensive stage small cell lung cancer. So initially we go for the voting for the pre-evaluation. What do we know about this? And we have, please scan the QR codes. And the first question is, what is the survival rate for small cell lung cancer? 3-year survival rates in small cell lung cancer does not exist. A, 5%, B, 15%, C, 12%, and D, 21%. Показатели трехлетней выживаемости раки при мелкоклеточном раке легкого не превышают
3-year survival rate in SCLC, it does not exceed over 5%, 15%, 12%, or 21%. So the second question.
Common form of small cell lung carcinoma in routine practice for a clinician. A, determination of EGFR ALK-ROS1, determination of PD-L1 expression level, C, determination of SLFN11 expression, and D, in a small cell carcinoma, the molecular genetic studies are not carried out in a routine practice. Я не буду повторять, это в ушах же есть. And the third question. And the third question is, what are the indications for talazoparib in advanced stage small cell lung carcinoma? A, patient with positive expression of SLFN11 who previously received chemotherapy plus atezolizumab. B option is patients with positive PDL expression of more than 30% who have not previously received anti-tumor treatment. C, patients with metastatic brain damage after the local surgical or radiologic treatment, and all patients who previously received standard course of polychemotherapy according to the scheme EP. So in a couple of seconds, we'll get our results. Let's see. Okay. Yeah. Okay, it's interesting. Да. Let's see what we will have in a couple of minutes. Okay, for the second question. Yeah. The most.
The majority of responders answered D, that in case of the small cell carcinoma, molecular genetic studies are not carried out in routine practice. And question number 3. Regarding the indications for talazoparib in the advanced stage of small cell lung carcinoma, the majority answered A, that patients with positive expression of SLFN11 who previously received chemotherapy together with atezolizumab.
So here are the disclosures for the authors. The small cell lung cancer is the most aggressive among all thoracic neuroendocrine tumors and also among all types of lung cancer, with 3 years survival rate only 12%. Extensive stage small cell lung cancer is often responsive to initial induction chemotherapy. It is often responsive pretty good. However, the most patients experience disease progression within a year of treatment initiation, and this is a big problem and challenge for us. Subsequent therapy outcome remains a challenging on disease progression, and responses are really very rare. Consequently, continuing to improve outcomes in a first-line setting remains crucial. Very high PARP expression in small cell lung cancer and large cell neuroendocrine tumors makes PARP1 inhibition as a potential therapeutic target in small cell lung cancer. Moreover, Dr. Byers and his colleagues found that talazoparib to be the most potent among all PARP inhibitors in preclinical studies. As a number of facts, SLFN11 predicted improved clinical outcome in a patient with small cell lung cancer treated with PARP inhibition. SLFN11 is a relatively new family of genes, which is relatively new discovered. They otherwise are called sleeping genes, why this term Schleffen comes from the German language. Sleeping genes, and they genes are mostly responsible for chemosensitivity of the drugs. So if there is expression of SLFN11, it is supposed that there is much more sensitivity to chemotherapy. So, as seen in the second curve, the patient with small cell lung cancer, SLFN11 positive expression exhibited an improved median overall survival of 12.2 months compared to only 7 months in patients without SLFN11 expression, treated with PARP inhibitors like vilaparib in combination with temozolomide. This was preclinical studies that give the idea for this current research. S1929 does not just offer a novel therapy, but also offers a predictive biomarker of SLFN11. And the strategy of the study was to randomize patients into either maintenance atezolizumab in a control arm or atezolizumab plus talazoparib in experimental arm therapy after following induction chemotherapy with platinum, etoposide, and atezolizumab. Hypothesis was that the addition of talazoparib to the maintenance atezolizumab will improve progression-free survival in SLFN11 positive small cell lung cancer. The primary endpoint of the study was progression-free survival. The secondary endpoints were overall survival, objective response rate, and assessment of adverse events. There was also the translational medicine objective here, and it was to bank the specimens for the future correlative studies. A couple of words about statistics. According to the previous report, SLFN11 prevalence has been shown to be 50% of small cell lung cancer population. It was expected that 85% of patients will have evaluable tissue, and that 68% of SLFN11 positive small cell lung cancer patients in a study will initiate maintenance therapy. Assuming the median progression-free survival of 4 months in a control arm, the design with 90% power to detect hazard ratio 0.56 using one-sided 0-point level rank text would require generally in overall 78 progression-free survival events, so this would be 7.2 months. It was expected to screen 323 patients in order to achieve 84 eligible randomized patients. Interim analysis performed when 50% of expected progression-free survival events would be observed. SLFN11 was assessed using immunohistochemistry, where any nuclear labeling was considered as to be positive, and any intensity, considered positive. And on the slide, we can see on the picture, figure A, we can see the positive expression of SLFN11 status, and on the figure B, we can see the negative expression of the SLFN11 status. 324 samples were submitted or resubmitted for the analysis, where 259 samples were evaluable, and that was 80% of the total. 204 patients had SLFN11 positive status, and that was 79%, and it was really much more higher than it was expected, because initially the investigators supposed that only half of patients, 50%, initial view was that just 50% of patients will have this SLFN11 expression, but currently they see that it was about 80%, 79. 55 patients had SLFN11 negative status, and that is 21%. Median time to obtain SLFN11 testing result was 7 days, like usual in immunohistochemistry. Yeah. 309 patients were registered for SLFN11 testing, where, as mentioned, 259 patients had evaluable tissue. Of them, 204 were positive for SLFN11, and from these 204, 106 patients were randomized, where 52 patients received maintenance atezolizumab, and 54 received atezolizumab plus talazoparib. Baseline demographics were well-balanced. And the study objective was, which was the progression-free survival, was met in the study. Patients who received atezolizumab plus talazoparib had an improved progression-free survival of 4.2 months compared to 2.8 months in control arm, with a hazard ratio 0.7, confidence interval 0.52, to 0.94 with a p-value 0.056. The follow-up was just 5 months. The overall survival data, of course, are premature, as follow-up was only just 5 months. However, they show a minimal improvement of 9.4 months median overall survival in patients who received atezolizumab plus talazoparib, to 8.5 months in patients who received maintenance atezolizumab with a hazard ratio 1.17, 80% confidence interval. So it was not statistically significant, of course. So the forest plots for the subgroup analysis was done in a small number of patients, and we can see that numerically, patients who received prior thoracic radiotherapy, patients with the brain metastasis, and patients with no liver metastasis and no bone metastasis, and treated in a study arm, had an improved outcome in terms of median progression-free survival. Best response rate was assessed in patients after maintenance therapy. However, 33 patients who had complete response or non-measurable disease after the induction therapy at a time of enrollment were excluded from the best response assessment. It was not statistically significant in remainder number of patients. Treatment duration was equal for cycles in both arms. However, in patients who were on atezolizumab, they had 72 days median duration of treatment, compared 97.5 days in atezolizumab and talazoparib combination arm. A couple of words about toxicity. The grade 3 or higher treatment-related non-hematologic adverse events occur in 30% of patients in a control arm, compared to 15% in experimental arm. Hematologic adverse events occurred 4% in control arms and 50% in experimental arms. And here, this is a really very huge difference in terms of hematologic adverse events. Only 3 patients discontinued treatment due to toxicity, 2 in control arm and 1 in experimental arm. Hematologic toxicities occurred in 19 patients, and it was 37% in atezolizumab and talazoparib arm, and was grade 3 anemia mainly. Grade 3 platelet toxicity also occurred in 9 patients, and it was 70%. Grade 4 in 4 patients, and it was 8%. However, despite the toxicities, no death toxicity with hematologic component occur in this study. Non-hematologic toxicity was mainly transaminitis and hyperglycemia. Grade 4 and grade 5 toxicities were also very rare. Both arms did not have treatment discontinuation due to toxicity and increased interval, and this is also a very important message. As a conclusion, S9029 met its primary endpoint, demonstrating the maintenance of atezolizumab and talazoparib improved progression-free survival in SLEPN11 positive patients with extensive stage small cell lung cancer. Hematologic toxicity was increased in combination arm as expected, mainly grade 3 anemia. This study demonstrates the feasibility of conducting biomarker-selected trials in small cell lung cancer, paving the way for the future evaluation of novel therapies in selected small cell lung cancer population. Investigators are currently analyzing the association of SLEPN11 expression to the levels of clinical outcomes. And on behalf of investigators, I also acknowledge all sponsors of this trial, and also all patients and caregivers, families, and teams that work on this study. Thank you very much.
Большое спасибо, Натя. Я хочу попросить сейчас проголосовать.
Many thanks, Nadia. And now let us vote. We postpone questions to Nadia until the end of the session, because our speaker from Spain, he is already online. So let us vote first, then hear a presentation from Spain, and then return back to Nadia. Thank you for your understanding. Please show us QR code again. Questions are the same. And we just like to remind you regarding 3-year survival rate. whether it will be higher or not. Yeah, the 3-year survival rate in SCLC doesn't exceed it over, and you can see the results.
Ответы готовы?
What about answers?
Да. Ну, внимательно
Yes.
слушали, да, до этого было, что
So
ответ был
before,
максимальный D, то
the
есть
maximum
большинство считало, что
of
20%
participants
средняя
answered D.
выживаемость.
Oh, you thought that 20%, but actually it's not more than 12%.
Да, к сожалению.
Пока так.
Пока так, да.
This is the way it is now.
Следующий вопрос
The next question is regarding the molecular genetic tests that we use in the case of the small cell lung carcinoma. The answers are different.
Аудитория послушала
And the
по
audience
поводу, да,
have heard the presentation about the expression of SLFN11.
Это не рутина, это еще очень-очень экспериментально.
This is a very experimental. Well, it should be accredited, and this is a topic for discussion because the small cell lung carcinoma, this is a big issue. Why in this study randomly there was chosen tazolaparib? We know it's a PARP inhibitor, PARP inhibitor, but it has high expression, but there is olaparib. Why this one particularly? And also to find driver mutations and predictors of heterogeneous cancer, and it's not easy to find small changes and moleculars because there is no consistency in the expression. This is the issue. But we still hope for future. Yes. And I would suggest to postpone the small cell lung carcinoma. We will continue it after the report of the Professor Luis Paz-Ares. Can you hear us?
Hello?
Hello. Very nice to meet you.
Same here. Thank you very much. Thank you. Nice meeting you as well.
Мы вас слышим замечательно. Большое спасибо. Я хочу вас представить.
Thank you very much, and I would like to introduce you to the audience, first of all. Can you hear the translation, by the way? Can you hear the translation? Professor, can you hear? Can you
Yes.
hear?
Hello, tell me. Are you able to hear me? Hello?
Sorry?
Are you able to hear me?
Professor, we can hear you very well.
Dr. Luis, can you hear me?
Yes, yes.
Before hearing your presentation, we will ask some questions for audience.
Okay.
The first question is,
Видите, ну давайте.
what is the correct
Dear Professor, can you hear us? Could you please
Yes,
choose the
yes.
English language? In
Yes,
the bottom, there is a globe sign. You will hear simultaneous interpretation from Russian to English.
Okay.
Can you please check the sound?
Okay. I got it now.
Can you hear me, Professor? This is interpreter speaking.
Yes, I hear you now.
Okay, very good, very good. Please stay on the English channel.
Okay, thank you.
Thank you.
And the first question is, what is the correct standard of first-line therapy in patients with advanced metastatic non-small cell lung cancer with PD-L1 expression less than 50%? A, it's combination cisplatin carboplatin with pemetrexed and the pembrolizumab. Second, cisplatin carboplatin with pemetrexed. And the C is pembrolizumab. Second question is, what kind of tumors are TROP2 hyperexpression detected? A, solid tumors, B, gamoblastosis, and C, melanoma. And the third question is, which drugs from antibody-drug conjugate group belong to TROP2 inhibitors? A, datoderuxtecan, B, satizumab govitecan, C, pembrolizumab, and D, A, and B answer together. Now it's time to see the audience answers.
Готовы ответить? Включите, если готовы. Аудитория 53% ответила, что...
So the audience answered to the first question, mainly A, that A is cisplatin, carboplatin, pemetrexed, and pembrolizumab. The second question was answered A, solid tumors, in case of TROP2 overexpression. And question number 3 was answered with answer G. The question was which drugs from the antibody-drug conjugate group belong to TROP2 inhibitors. So it includes datopatomab deruxtecan and sacituzumab govitecan. Can you hear us?
Doctor,
You start.
I hear you perfectly.
You can read your report.
You
I
start.
saw the result of the questions as well. So, did you like me to start my presentation already?
You start,
Okay,
please.
Okay, thank you very much. So, first of all, really, I just like to thank the organizers of this Best of ASCO Kazakhstan for inviting me to give this presentation. I'm really, I suppose that you're seeing now my screen. I'm really glad and honored to be presenting on behalf of all the TROPION-Lano2 investigators the result of this trial of datopotamab deruxtecan plus pembrolizumab with or without platinum-based chemotherapy in advanced non-small cell lung cancer. You see here some of my, let's say, conflict of interest. And as you know, this presentation was already done at the ASCO 2023 oral presentation session in lung cancer. And the presenter there was Dr. Goto, some of the co-PIs of the trial with me. I think all of you are aware that datopotamab deruxtecan, that I call it dato, is an antibody-drug conjugate, which is composed of anti-TROP2 humanized IgG1 monoclonal antibody, and then of deruxtecan, which is composed of cleavable tritipeptide-based linker plus a topo-1 inhibitor base load. And you know that the dose of 6 milligrams per kilogram of datoderuxtecan as given in monotherapy had demonstrated encouraging activity on prior trial in non-small cell lung cancer in patients with advanced pre-treated disease with an overall response rate of nearly 30%, actually 28%, and a median duration of response of 10.5 months. Of course, the drug has been evaluated in a number of preclinical trials. I'm just showing here you the result here of this, let's say, combination trial on the MC38 mice model, where the drug had been combined with anti-PD-L1 drugs. The drug had been combined, as you see here, at different doses with the PD-L1 antibody, showing clear improved results as compared to the drug given alone or, of course, controls. So there is a clear potential for synergistic or at least additive effect. Indeed, that is being shown as well in other tumor types. And in the Begonia phase 1b/2 trial, the combo of dato, deruxtecan in the first-line setting in patients with triple-negative breast cancer show an overwhelming response rate of 74%, including a CR rate of 8%, which is really pretty interesting at this stage. So you see here the design of the TROPION-Lung2 trial in patients without actionable genomic aberrations of non-small cell lung cancer. Eligibility, as I said, patients with advanced disease and should have, during the dose escalation phase, less than 2 lines of prior therapy. And we clearly evaluated 2 strategies. One strategy was a doublet of dato, deruxtecan plus pembro. We always use the doses of 200 milligrams of pembro, and we use 2 doses, 4 and 6 milligrams. Then we started to evaluate as well triplets, and we evaluated triplets with carboplatin in cohorts 3 and 4, and cisplatin cohorts 5 and 6. Important, we always use 2 doses of dato, 4 and 6 milligrams, as we did in cohort 1 or 2. And interesting, the initial cohorts included some pre-treated patients, but from cohort 2 in the 13th of June 2022, only treatment-naive patients were included. So let's say, particularly in the last few cohorts, most of the patients were patients without prior treatment. You see here the baseline characteristic of patients included. Overall, nearly 150 patients were actually included, 64 in the doublet, 72 in the triplet cohorts. Those were the typical patients with non-small cell lung cancer, median age 65, 70% of the patients being adenocarcinoma, typically split by PD-L1 expression, including some 20-25% of the patients being high expressors. As I said, patients were different, some treated or not previously. Out of the patients with the doublet, some 58% of the patients were treated in the first line. With the triplet, that was the case for 75% of the patients. Still, as you see here, more than 40% were second line. With the doublet, 25% was the case in the triplet therapy. At the time of doing the data analysis, some 36 and 46% of the patients, the doublet and triplet, were still on treatment, and the rest had discontinued treatment. The median number of treatments was about 6 or 7 cycles, and the main reason for discontinuation was, in some 15% of the cases, adverse event, progressive disease in 1/3 of the cases. You see here, in terms of anti-tumor activity, responses were seen quite frequently in about some 50% of the patients overall. You see here, for those patients, including first and second line, responses in 38% of the patients treated with the doublet and 49% of those treated with the triplet. If you just go to the subset of patients treated first line, responses were seen in 50% with the doublet and 57% with the triplet. Of course, most of the patients being partial responses. Disease control rate was really interesting as well, more than 80% in any subset, being about 84 to 87% in all patients. In the subset of patients with first line, more than 90% of the patients, 91%, had a good disease control rate. And as you see here, median PFS was in the range of 8 months, doublet and triplet. You see here the forest plot, which is very consistent with the fact that some 90% of the patients really had some disease control rate, and about 50% of the patients had a response. Again, as you see here, the spaghetti plots in terms of duration of the response, you see here that responses were seen at any level and disease control at any level of PD-L1 expression. In the doublet, you see that most of the long-term let's say, responders or patients with disease control was in patients with more expression of PD-L1 in red. However, you look at the triplet, any patients may have a long-term disease control, and that includes in dark blue those patients also treated with negative PD-L1 expression, though it was very clear with the triplet combination. In terms of safety, I would say overall there were no new signals. We have seen the typical side effects you would expect from what is known with datoderuxtecan alone and also with immunotherapy. Some, let's say, more side effects were of course seen for patients treated with the triplet as compared with the doublet, and indeed looking at those data, some 23% of the patients receiving the doublet and 28% receiving the triplet had some treatment emergent adverse event that led to discontinuation of the drug. As you see here, discontinuation 28% doublet, 38% with the triplet, and still, importantly, all these deaths that were observed during the treatment, none of them, except for one case of pneumonitis, was associated with the drug. And indeed, this case of pneumonitis were finally not adjudicated to the drug by an independent adjudication committee. You see here the more relevant side effects. I would say more important were stomatitis, nausea, fatigue, asthenia, and some anemia. Looking at the data, most of the cases were grade 1 or 2 in the dark colors, and in the light blue or light red, you see grade 3 or 4 that were not very frequent. If I have to highlight something that you see more frequently in the triplet is particularly hematological side effects, anemia, thrombocytopenia, and of course neutropenia. But that was most of the cases grade 1 or 2. If we look at some of the relevant toxicities, such as mucositis, that is a frequent event happening with datoderuxtecan, happening in some 50% of the cases, doublet and triplet, being in some 6 to 8% of the cases grade 3 or more. Pneumonitis, some 20% of the patients, and very rarely occurs, as you see here, grade 3 or grade 4. Ocular toxicity also happening in some 20 to 25% of the cases, being rarely grade 3 as well, and that is relevant to show. And some 15 to 25% of the cases also, as you see here, had some infusion reactions as well. So just let me therefore conclude more or less about this study. The combination of datoderuxtecan plus pembro with or without platinum chemotherapy, doublets or triplets, let's say, have shown encouraging activity. Remember, in the range of 50%, being nearly 60% for those patients treated first line. And activity have been seen across the different levels of expression of PD-L1, which is important. No new safety signal were observed in this trial, being the more frequent adverse events, stomatitis, nausea, anemia, and asthenia. So therefore, I think there is rational to further explore those doublet and triplet combination of dato, deruxtecan plus pembro in first-line advanced non-small cell lung cancer, and actually two very relevant trials are already ongoing. The TROPION-Lung08 trial, which is concerning patients with first-line non-small cell lung cancers, PD-L1 expression in at least 50% of the tumor cells, and patients are randomized on a 1-to-1 fashion to standard of care pembro versus dato plus pembro. Endpoints being PFS and OS, co-primaries. The LAN07 TROPION trial is, again, first line, but is having patients with PD-L1 expression less than 50%. That means negative for 1 to 49. And here there is randomization to 3 arms, experiment, let's say control arm being pembro plus pimetricid plus platinum compound, and the 2 experimental arms being the doublet, dato plus pembro, or the triplet, dato plus pembro plus platinum agents. And I think those data are, those trials are already ongoing. We thank all the patients and family caregivers for their participation in that particular trial. Also like to acknowledge the role of the sponsor, the ICI and AstraZeneca in this case, and all the support given by the agencies that were funded by the ICI in terms of the editorial support. So thank you very much, and I'll be happy to answer any question or any comment you may have about this presentation. Hello?
Yes, can you hear us, Professor?
Yes, I hear you now.
Okay, very good, very good. We're waiting for the questions from the audience.
Luis, большое спасибо за вашу
Luis, many thanks for your presentation. Thank you for your precious time you dedicated to our event. Any questions from the audience to Luis, please? TROPION-1 in triple negative cancer. Any data on triple negative cancer of breast cancer? Because NASCO were published, but TROPION also has triple negative breast cancer results. Any preliminary results of TROPION-1 triple negative breast cancer are published or not yet?
Yeah, so I mean, you know, I have to disclose I'm not a breast cancer doctor. The only thing I may say, there are strong data suggesting the role of dato plus a durva or PD-L1 inhibitors in the setting of preclinical trials, preclinical experiments in triple-negative breast cancer models, and the Begonia phase 1b/2 trial that had already been presented at least at the AACR by Dr. Okahima and at the San Antonio meeting by Dr. Smith show very interesting response rates in the range of 75%. 3 out of 4 patients were actually responding, including some significant number of patients having a complete response. So I would say very interesting data in that particular subset of patients with triple-negative breast cancer in advanced metastatic disease, first line.
Thank you, because it is very interesting. The drug actually impacts the new mutation of TROP1, and that's what I wanted to say. And I think no more questions there. I want to thank you, Doctor, for your excellent presentation, for giving us an overview of the new prospective drugs which are currently on the clinic stage 1 trials. And I think the clinical trials will give more emphasis for these drugs for non-small cell carcinoma. Thank you very much.
Thank you. Thank you very much. Have a nice day.
Thank you, Luis.
Спасибо, Luis. Thank you again.
Наш сегодняшний день заканчивается, но мы же обещали
We're about to
пообсуждать
finish today's session, but we also promised to discuss non-small cell carcinoma, and we still have time to discuss this with Nadia. Nadia, please take the mic, and we can continue to discuss this. Kaldegul. Thank you very much. I have a question on talazoparib. I have a patient with breast cancer. For more than 2 years, she received talazoparib, and one of the side effects that is anemia, dropping of hemoglobin below 50, and now we have hemotransfusia to help her. Any other methods to correct her status? Apoetins, can we use apoetins? Well, apoetins under these circumstances is quite doubtful. We don't use them at all. With the talazoparib, usually we don't use them for a long time already. And, well, thank you. We try to control side effects depending upon the phase of treatment, either with dose reduction or extending intervals in order to give the brain give her to restore, and they have different approach in electropoietin. Our foreign colleagues, they are controlling this patient as well. Well, we use blood components transfusions. If it is critically and symptomatic, critically, it is not only about hemoglobin, but also we are checking other other things like symptoms, general performance below 80 plus hematocrit below 23. So we try to assess comprehensively the status of these patients, because several years ago we have clinical studies that electropoietins probably stimulate cancer. This was probably 5 years ago when we have it, and we don't use it for a long time already. When we're talking about small cell carcinoma, this is very interesting topic, and I would like to ask you another question regarding PDL activity and whether we need this. Are there any direct correlation of PDL activity in small cell lung carcinoma and response to immunotherapy? There's no correlation between these two things. And I just wanted to say when we discussed this, that small cell carcinoma, the registration for telemizumab was recalled, and now telemizumab is not recommended for small cell carcinoma. And the study which Nadia presented to us actually is not yet completed. And of course, there are supporters of this therapies and opponents of this therapy, and only time will tell. And this is quite discursive topic. Maybe there will be some other research, and maybe then we can have it in a greater details. And speaking about the drivers of this mutation, it is quite difficult to understand that when we're talking about small cell carcinoma, what is the driver? Because we had a number of cases, there was a comprehensive genome profiling. There are different patients, different therapy opportunities, and what is the important mutation and what is considered as a backdrop mutation. And maybe this mutation will be a driver for small cell carcinoma, because anyway, if there are some predictors, it is easier for us to understand, and our therapy opportunities could be more targeted. In this regard, I just would like to return to this question, because when we had some driver mutations in small cell carcinoma, we've got more than 100 mutations. It was very difficult to understand under these circumstances, because the nature of non-small carcinoma, it is actually different from small cell carcinoma. It is heterogeneous, and that is why it is neuroendocrine cancers, which is very difficult to tackle. And as far as this research, the second stage didn't give us more. There are some good results, but considering this toxicity which they demonstrated and improvement of event-free survival for 1.5 months, of course, the risk overweights the benefits. And that is why, if we are talking about the importance of this treatment only after completion of the third phase. And when we're talking about clinical research, and the previous speaker spoke about real clinical practice, which is slightly different from other types of research, because there are selective requirements in clinical studies. When we included status performance 0 and 1, and in clinical performance settings, we almost have less than 1. Dear colleagues, we're about to finish our section. First of all, I want to thank all the speakers, Nia, Nadia. The lively discussion is very important. Now, I would like to invite everyone to come to the podium, and we will have a group picture dedicated to the end of this event.
Наша цель ясна. Она не изменилась. Мы расширяем границы науки, чтобы предоставить лекарственные препараты, способные изменить жизнь. В наши дни наука развивается как никогда быстро. Не отставать и держаться на равных – непростая задача. Мы должны продолжать добиваться новых результатов. Оставаться лидером. С помощью нашей коммерческой деятельности, с помощью нашего бренда. Вот из чего мы созданы. Сила научных достижений.
It is the future that calls us, our history that forms us. It is a passion that drives us for doing now what patients need next. Together as one, we pursue a better tomorrow. An ever-forward evolution of discoveries across boundaries, among partners, beyond failures, around the world. There are countless reasons why we do what we do every single day. But at the core, it is about our most precious gift: life. Life in all its beauty and its complexity. Life as moments to be experienced, shared and remembered. Life as possibilities beyond the horizon. Life transformed by science, from despair to hope. In 2021, we come together to celebrate where we have been, what we're doing, and where we'll go next. To celebrate 125 years. To celebrate all of us. To celebrate the future. We come together to celebrate life.
We are here together to celebrate life.
Каждые 2 секунды у кого-то в мире диагностируется рак. Это не просто статистика, это близкие нам люди. Поэтому нет ничего более срочного или более личного, чем наша цель – найти способы излечения от этого смертельного заболевания. Но мы знаем, это чересчур грандиозная цель, чтобы справиться в одиночку. Мы сотрудничаем с научным сообществом, чтобы открыть новые методы лечения, используя силу реальных доказательств для более точного действия наших препаратов. Сотрудничаем с группами защиты прав пациентов для поддержки и расширения прав и возможностей людей, которые живут и борются с раком. Взаимодействуем с организациями здравоохранения для предоставления доступа к нашим лекарствам тем, кто в них нуждается. Вместе мы достигли значительного прогресса, но наша работа далека от завершения. Рак забирает миллионы жизней каждый год. Чтобы превратить истории потерь в истории надежд, мы все должны объединить свои усилия. Чтобы найти способ победить рак, мы все должны объединиться.
Караганда. Индустриальный центр и магистральный узел железнодорожных и воздушных путей. По своему экономическому и научному потенциалу она по праву занимает одно из ведущих мест в республике. Именно здесь было создано первое в Казахстане предприятие, производящее современные, высокоэффективные биотехнологические препараты. Карагандинский фармацевтический комплекс. В создании завода было инвестировано более 100 миллионов долларов. Мы первое предприятие в Казахстане, производящее препараты в асептических условиях, соответствующие международному стандарту надлежащей производственной практики.
В Казахстане были созданы благоприятные условия для привлечения инвестиций в отечественную фармотрасль, и в результате чего и было создано наше предприятие.
Карагандинский фармацевтический комплекс. Мы осуществляем трансфер технологии производства биотехнологических лекарственных препаратов для лечения таких социально значимых заболеваний, как онкология, гемофилия, ревматоидный артрит, сахарный диабет и других редких болезней, которые ранее здесь не производились. Впервые в Казахстане внедрена технология производства препаратов в преднаполненных шприцах.
Все наши производственные цеха спроектированы и построены в соответствии с международными стандартами надлежащей производственной практики. Цех оснащен современным европейским оборудованием, позволяющим производить препараты высокого качества.
В 2015 году у нас основана испытательная лаборатория отдела контроля качества. В нее входят физико-химическая лаборатория, микробиологическая лаборатория, и единственная в республике биохимическая лаборатория, выполняющая анализы биотехнологических препаратов.
Мы производим биотехнологические инъекционные лекарственные средства, требующие особых условий при хранении, производстве, транспортировке и контроле качества. В связи с этим нами выстроена фармацевтическая система качества на требуемом уровне для обеспечения населения качественными, безопасными и эффективными лекарствами.
Наш современный фармацевтический склад оснащен холодильными камерами для хранения лекарственных препаратов со специальным температурным режимом и морозильными камерами для хранения активных фармацевтических субстанций и вакцин. Датчики контроля взаимодействуют с центральной диспетчерской службой. Это позволяет осуществлять круглосуточный контроль температурного режима, мгновенно реагируя на любые изменения. Транспортировка наших лекарственных средств осуществляется валидированными авторефрижераторами. Мониторинг безопасности препаратов ведется и после его доставки.
Процессы производства поддерживаются инженерными системами мирового уровня. Системы электроснабжения, теплоснабжения, водоподготовки и воздухотехники обеспечивают безаварийную работу предприятия.
В нашей компании работают высококвалифицированные специалисты. Для повышения уровня профессиональной подготовки сотрудников на предприятии реализуется четко организованный план по развитию и обучению. Мы взаимодействуем с крупнейшими медицинскими вузами страны для подготовки молодых кадров.
Миссия нашей компании – обеспечение населения нашей страны безопасными, эффективными и доступными лекарствами.
Наша приоритетная задача – это сохранить и приумножить здоровье нации, создавать рабочие места и быть активным участником развития своей страны. Быть лучшими не только в Казахстане, но и за его пределами.